Today, we are having the ninth CME of our organ donation committee. And I welcome our president, Dr. K.M. Abul Hassan sir. Even with his busy schedule, he is able to attend all the meetings. And I welcome Dr. R. Gunasegaran, the National Vice President of IMA Headquarters. I welcome Dr. Sendamil Pari sir. I welcome Dr. Sengutuvan sir, the State President-elect to 2024. Dr. B. Sridhar sir, President-elect 2025. Dr. Karthick Prabhu sir, our Honorary Secretary, he is traveling, it seems, so he will not be joining. And Dr. Gauri Shankar sir. I invite our State President, Dr. K.M. Abul Hassan sir, to inaugurate the session of the organ donation CME today, 9th month.
Thank you, Dr. Rajesh. Good afternoon, all of you. Dr. Gunasegaran, our National Vice President, and all the office State Branch, and also members of Organ Donation Committee. I also thank and welcome today's faculties, Dr. Karthick Prabhu and Dr. R.M. Subbaiah. I congratulate our Organ Donation Committee at the outset that every month without any break, Dr. Rajesh Babu and team had organized continuous CME programs, webinars on Zoom regarding organ donation, one organ and 1 month, like that. I think the end of the year, it will be a very great function in one of the institutions in Coimbatore, which is organizing organ donation awareness for the society and also for the students. This is a need of ours. I always said in all the meetings that it is our duty to educate people about organ donation, because organ transplantation is one of the milestone development in allopathy, in our modern medicine. So we will have to promote it so that many lives can be saved, many lives suffering from organ failures can be saved by organ donation. Particularly in the area of cadaveric donation, we are still lacking. Live donor donation are happening with regards to kidney donation or liver donation. But the cadaveric donation would give us lots of organs, large number of organs, so that large number of people can be saved. So I think we are moving in that direction, educating our doctors first and also educating our society. So once again, I congratulate our IMA Tamilnadu State Branch Organ Donation Committee for taking this cause very dedicatedly, close to their heart, and doing their programs very, very sincerely. And I wish all the delegates who joined today have a very good messages to carry forward in your practice and also in our career. Thank you very much for the opportunity, Dr. Rajesh.
Now I invite our National Vice President, Dr. Gunasegaran sir, to give his felicitations.
Good evening, everyone. Respected President Dr. Abul Hassan, Dr. Rajesh Babu, Chairman of the Organ Donation Committee, and members of the Organ Donation Committee, and today's faculty members, Dr. Karthick Prabhu and Dr. R.M. Subbaiah. This is the 9th consecutive organ donation meeting to enlighten our members. Definitely, our members will be benefited. What are all the organs can be donated? What are all the organs can be harvested from the live or the cadaveric body, and how it is useful? Everybody should know. And also, we should propagate the messages of organ donation to the public. It is more important. So, after finishing this, enlightening our members every month, simultaneously 1 or 2 meetings for the public throughout the state by our IMA members to be done, and give an awareness for about the organ donation. And today we have the blood donation and also the bone marrow transplant by eminent speaker. Our Dr. Karthick Prabhu is looking after the blood bank in the IMA Coimbatore blood bank. So he can able to give a view about how to manage the blood bank. And our hematologist from Trichy, the Kaveri Hospital hematologist, Dr. R.M. Subaya, he is the only one hematologist in Trichy for the whole medical community here. And he is doing very good job and enlightening periodically. He is giving messages through WhatsApp and other things to our members about the hematology problems. And I hope he will give throw more light on the that is more bone marrow transplantation and the stem cells also. With these few words, I congratulate the Organ Donation Committee, Dr. Rajesh Prabhu and other members, and wish the today's program a successful. Thank you.
Now I invite immediate past President Dr. Sennavil Pari sir to give his felicitations. I think sir has not joined. I requested him, and Dr. Sridhar also has not joined. And so we don't have other leaders. So straight away we will go to the topic of the day. And the first topic today will be, the main thing today is that we are conducting donations of the blood donation and bone marrow donation. Already we have covered all the other organs, each and the visceral organs and rules of the organ donation, the brain death certification and all those things. And what we thought was we will conduct about the blood donation, which is commonly is done. And next month is going to be the blood donors, World Blood Donor Day is going to come. So I thought we will have the blood donation, and the apt person today is Dr. R. Karthick Prabhu, who is a consultant pathologist. And he is the blood bank medical officer of the Indian Medical Association of the Coimbatore. He is going to talk about the blood banking insights, basics, and beyond. I welcome Dr. Karthick Prabhu sir to give his lecture on blood donation.
Thank you.
Welcome
Thanks
you,
for the
sir.
opportunity. Good evening, one and all. Thanks a lot for this opportunity. This forum is kind of new for me. Though my topic is basic, it's the need of the hour actually. So, I am from IMA Blood Bank Coimbatore. I would like to use this opportunity to address the global scarcity or the gap that prevails regarding the blood donation. The main agenda for me for today is to promote the blood banking and also to stress more on the blood donation. The need is actually real and the scarcity is actually more. So we need to keep upgrading and we keep the mind open to promote the blood donation and also tell our patients regarding the same. The blood in the scarcity, I used to tell to my patients that the blood is your property. Definitely, you have to know something about it. And blood is usually ignored, and no one is much interested about to know about it. And it's also always a taboo in the common practice. So I used to tell the patient regarding that. And as we all know, the blood is scarce. Blood is very scarce and the precious human resource. There is no substitute for blood. Despite the huge population, the demand-supply gap for blood units is still wide. According to WHO 2012 report, only 9 million units are available annually, and the demand was 12 million units. So this is the basics for a presentation. The blood, as we know, constitutes around 8% of our body weight. That is just 5 grams. And then, so next discovery, the history is like Carl Landsteiner discovered why when different people that was mixed as blood cells something exploded. In 1901, he found the different blood groups. And they got the Nobel Prize in the physiology in the year 1930. So the first blood transfusion happened was way back in 1795 in Philadelphia. He performed the first, Philip Young physics performed the first human blood transfusion, although he does not publish the same. In 1818, James Blundell, a British obstetrician, performed the first successful transplantation of human blood to a patient for the treatment of postpartum hemorrhage. So this is till date 1818 is the first another transfusion. So as we all know, the blood group ABO is a common blood group, and it has totally ABO totally there is 8 blood groups are there. And as such, எப்படி நம்ம டெஸ்ட் பண்ணுவோம்னா the 2 methods பண்ணுவோம். One is the tube agglutination method, another is the gel card method. The gel card method is nowadays used everywhere, but basic சின்ன setupல they are still using the tube agglutination or a tile method. So even though tile method is outdated, but still many places they are following only that method. So what is blood typing? The blood typing is the process of classifying the blood into the blood groups based on the laboratory test to reveal the presence or absence of particular antigens on the surface. Depending upon the clumps based பண்ணி we will tell whether it is positive or negative. So இந்த மாதிரி invalid இந்த மாதிரி எல்லா clumpsமே வந்து clumps வந்துச்சுன்னா it's invalid report. So இந்த மாதிரி D ல clump வந்ததுன்னா positive அந்த மாதிரி நம்ம சொல்றோம். So these are the totally 8 groups available. As we all know, universal universal donor is O negative universal donor, and AB positive is universal recipient. Like this. So what are the benefits of blood transfusion? So this is the basic people need to know that beneficial is first one is it is beneficial for the human heart. What we suggest is at least every year they should donate blood. Abroad at least 2 months, yearly twice the blood donate பண்றாங்க. But India one yearly once பண்றக்கே people are thinking. So we need to promote that at least yearly once donate blood we have to tell. And also tell that it also reduces the cancer risk and boosts the production of red blood cells. It lowers the cholesterol levels. It helps in the weight loss. And also it helps in fighting about the hemochromatosis. And once the blood donation is done, the patient, the donor themselves feels very rejuvenated. So அவங்களுக்கே ஒரு எனர்ஜி வந்த மாதிரி இருக்கும், and they also start promoting further. So always the first step matters. Once they start giving, they furtherly they do it further. அந்த மாதிரி அப்புறம் வந்து also another advantage about blood donation, what people we used to tell is by doing this they can get automatically screened for the infective diseases. They can get screened free of cost. Once blood donation பண்ண போனா automatically we will check for the hemoglobin, automatically we will check for the other infectious disease இருக்கும். Anyway we will screen and we will give the report. So that is useful for the patient also. So this is the website for the National Blood Transfusion Council. These are the details about everything. Here we can find the total number of blood banks listed, the register as a donor we can get, and we can get a card also, and the schedule the donation. Everything is we can do in this website. This is a government-based website. And then even though we are doctors, the one thing that most people not aware about what happens in this blood bank. We will talk about blood bank. We will talk about everything, but so we have a little idea about what to expect inside a blood bank. So inside a blood bank, one area should be there. One is the reception, next is the vital checking area, and the third is the donor area, and the fourth is the reception area. This is the main 4 areas here. So reception, there should be request form. We have to check a person to check the request form, and the inquiry or the questionnaire in both native language as well as English language, and then counselor should be there ideally, who should psychologist who should give the pre-test, pre-donation, post-donation counseling also should be given. And then vital check should be done in another area where the hemoglobin blood group is checked there itself, and the BP is also checked to check whether they are fitting into the donor criteria. And then donor area, in donor area there will be the reclining posture, the venous section is done, and then followed by the refreshment area. Once the blood donation is done, the refreshment patient is sent to the refreshment area. So ideally the setup should be like this. The recliner should be placed like this, and the patient be placed comfortably, and then blood donation has to be taken, venous section has to be done comfortably. So this is the position. And then what we see here is the blood collection monitor, which actually automatically senses the weight and automatically cuts off until the required amount of blood is collected. So blood is in the state of agitated state, and the patient maximum within half an hour to 45 minutes, whole process will be completed. So total time taken is 30 to 45 minutes. The quantity collected is 350 to 450 ml. And then the next area is the screening area. This is the most important area to rule out the TTA, that is transfusion transmitted infection. We have to rule out, that is HIV, hepatitis B and C, syphilis, and malaria. These has to be ruled out, and then only we have to tag it as a screened blood and kept in the storage device. So this area is the segregation area. Segregation area should be separate from the screening area. Once the screened bloods are taken, we should take it and segregate them and place it accordingly, and mention that this is screened blood and unscreened blood we have to mention. And here, as we see here, there are multiple fridges are there depending upon that. One is the plasma freezer, next the platelet agitator, and the deep freezer. Depending upon the component, we have to store them accordingly. So next is the criteria. So what criteria? Age criteria is, 18 to 65 years of age is the age limit. Weight, the donor should not be less than 45 kgs. The pulse and temperature should be normal. The blood pressure should be within normal limit. The childbirth should have delivered 1 year ago and stopped lactation. The hemoglobin should not be less than 12 grams, 12.5 grams ideally. So regarding immunization, the donor should not have the immunization of the following: that is cholera, typhoid, diphtheria, tetanus, அதெல்லாம் பண்ணிருக்கூடாது. And gamma globulin past 15 days பண்ணிருக்கூடாது. And rabies vaccination last 1 year you should have done. அப்புறம் scars or skin puncture, arms and forearms should be free from tattoos. But tattoo skin puncture or scars should be indicative of intravenous drug abuse இருக்கறனால it should be careful and cautious, and proper detailed history has to be taken. The tattoo பாத்தீங்கன்னா 1 year முன்னாடி tattoo போட்டிருந்தாங்கன்னா we should avoid that. And then the cancer should not have any form of cancer. We should defer them from donating it because they will not be much aware about the details. So for safety reasons, we should be avoid the cancer patients. And then what are the types of donor? That is 3 types. That is donor the 2 types: voluntary and replacement donor. So voluntary என்னன்னா those who donate on their own. And the replacement donors, that is blood bank costs, that is from within the patient's own family or community only we are recommending. They should not bring from other person or from money. They should not bring people for money. So replacement is usually asked from the blood bank only for the reason is to get blood from their own relatives or their own community. And then autologous blood donors are those who donate blood for their own cells. And apheresis is a common trend now because the single donor platelet is of much importance now. So that's donating blood components through the process of cell separation. So that is the apheresis donor. And what patients should be aware of is the red flags. The red flags, alcohol. Red flags the donor should be aware of. That is alcohol. Alcohol should be avoided 24 hours prior to blood donation. And the smoking should not be done 1 hour before donation. And the jaundice, a travel history or history of any sexual contact need to be intimated prior. அப்புறம் மெடிசின்ஸ் பார்த்தோம்னா ஆன்டிலிப்டிக், ஆன்டிசைக்கோட்டிக் அண்ட் கீமோதெரபி இன்டேக் எடுத்துட்டு இருந்தாங்கன்னா they cannot donate the blood. And heparin and anticoagulant therapy needs to be aware and should inform the details properly through the consultant. அப்புறம் இன்ஃபெக்ஷன் பார்த்தோம்னா should not have hepatitis B, C, tuberculosis, leprosy, HIV இருக்கக்கூடாது. Heart disease should not have any heart diseases during at the time of this is a common thing happens. Dentist பண்ணலாமா வேண்டாமா usually common taboo இருக்கு. things பண்றாங்கன்னா they can do. But இப்ப 3 days after extraction அப்புறம் 3 days அப்புறம் they can give. அதே மாதிரி they have bleeding இருந்துச்சு உங்களுக்கு, அந்த மாதிரி ப்ரொசீஜர் பண்ற bleeding இருந்துச்சு அப்படின்னா it's better to avoid. சரிங்களா? So diabetes பார்த்தோம்னா if resolved and controlled by oral hypoglycemic agent they can give, but for insulin injections and insulin எடுத்துட்டு இருந்தாங்கன்னா they need not give blood. But drugs பார்த்தோம்னா IV drug abuse இருக்கு, இல்ல கையில ஏதாவது marks இருக்கு அப்படின்னா straight away we need to avoid them from donating the blood. So next is the blood components. So blood components என்னன்னு பார்த்தோம்னா இது right, இது actually என்ன சொல்லுன்னா transfusion is a specific part of the blood rather than the whole blood. It ensures the right component to the right patient in the right amount at the right time. So தேவையான அளவு தான் நம்ம கொடுப்போம், எதுக்கு தேவையோ அதுக்கு தான் கொடுப்போம், unnecessary wastage ஆகாது. So blood component is the most ideal thing to give. So if donate பண்ணிட்டாங்க, so என்ன பண்ணணும் patient அப்படின்னா they should have proper they hydrate properly, drink plenty of water. If they feel anything uncomfortable or dizzy, they need to inform it prior, and they take adequate rest எடுத்துட்டு they iron supplement அதை எடுத்துக்கலாம். So என்ன பண்ணக்கூடாதுன்னு பார்த்தோம்னா do not drink alcohol for 24 hours. The bandage இருந்துச்சு அப்படின்னா you should remove it, and you should not perform any heavy exercises or any vigorous activity for 24 hours. So back to history, the blood transfusion war and cryo time என்ன பண்ணிருந்தாங்க அப்படின்னா they first அப்பதான் blood bank start பண்ணாங்க. என்னன்னா first frozen blood prepare பண்ணாங்க. என்னன்னா 1966 தான் first they have started the frozen blood bank in the war zone. So from that only everything started. So this was the bottle used during the World War. So it was like a glass bottle. So next generation nowadays we're using the plastic this thing. So they've been part. So blood bag. We needed everyone need to know about the blood bag because as we write blood dispose பண்ணிடுவோம். But அது என்ன இருக்கு அப்படின்னு first we need to know the basics also. The blood bag basically contains the anticoagulant and also enrichment medium. அது எதுக்குன்னு பார்த்தோம்னா to maintain the proper environment. உள்ள நமக்கு எப்படி இன்வைவோ இருந்ததோ அதே மாதிரி இதை வந்து வெளியவும் நம்ம ப்ரொடியூஸ் பண்றதுக்காக enrichment medium இருக்கும். ஸோ என்னென்ன போட்டிருக்குன்னு பார்த்தோம்னா there should be collection date, collection time, யூனிட் நம்பர் மெயினா என்ட்ரா இருக்கணும். எப்போ எக்ஸ்பைரி ஆயிருக்கு அப்படின்னு போட்டுருக்கணும். அப்புறம் ஸ்கிரீன்டா அன்ஸ்கிரீன்டா அப்படிங்கிறது should be mentioned. அண்ட் வந்து வாலண்டரி டோனர் கொடுத்தாங்களா என்னன்னு எழுதி இருக்கணும். அப்புறம் வந்து வாட் டைப் ஆஃப் பிளட் அப்படிங்கிறது குரூப் அப்படிங்கிறத வந்து இங்க பிளாக் லெட்டர்ஸ்ல தே ஷுட் மென்ஷன் இட். ஸோ திஸ் இஸ் கால்ட் அஸ் தி லேபிள்டு பிளட் பேக். இந்த மாதிரி இருந்தா மட்டும்தான் யூ ஷுட் கலெக்ட். இப்போ எனிதிங் இந்த மாதிரி கொடுக்காம சின்ன சின்ன பிளட் பேங்க்ல ஏதாவது வந்து எரர் பண்ணி அமிச்சாங்கன்னா யூ ஷுட் ஸ்ட்ரெயிட் அவே சென்ட் இட் பேக். ஓகேங்களா? ஸோ அதுக்காக தான் போட்டுச்சு. ஸோ டெஃபினெட்லி தேர் ஷுட் பி ப்ராப்பர்லி லேபிள் பிளட் பேங்க் ஒன்லி ஷுட் பி அக்செப்டட் இன் எனி ஹாஸ்பிட்டல் ஆர் எனி செட்டப். ஸோ ஃபர்ஸ்ட் யார் அதை இன்ட்ரடியூஸ் பண்ணாங்க அப்படின்னு பார்த்தோம்னா இன் 1943. ஸோ வந்து பேட்ரிக் அப்படிங்கிறவர் தான் ஃபர்ஸ்ட் ஏசிடி அப்படின்னு கண்டுபிடிச்சாரு. ஏசிடி என்ன அப்படின்னா ஆசிட் சிட்ரேட் டெக்ஸ்ட்ரோஸ். அதை நம்ம இன்னுமே யூஸ் பண்றோம். அது என்ன அப்படின்னு பார்த்தோம்னா தட் இஸ் தி anticoagulant and the enrichment medium we use in the blood. So because of that only we are having the proper shelf life. That is 42 days the shelf life we are having it mainly because of ACD. So ACD என்ன பார்த்தோம்னா ஆசிட் சிட்ரேட் டெக்ஸ்ட்ரோஸ். அப்புறம் வந்து 1950 கார்ல் வால்டர் தான் ஃபர்ஸ்ட் பிளாஸ்டிக் பிளட் பேக் வந்து ஃபைண்ட் அவுட் பண்ணாரு. அண்ட் இன் 1963 to 1970 அந்த 10 இயர்ஸ்ல க்ளோஸ்ட் பிளட் பேக் சிஸ்டம் அப்படிங்கறத வந்து டெவலப் பண்ணாங்க. எதுக்காகன்னு பார்த்தோம்னா ஆல்தோ தி டெவலப் பிளாஸ்டிக் பிளட் பேக் தி இன்ஃபெக்ஷன்ஸ் வேர் மோர் காமன். ஏன்னா ப்ராப்பர் ஹைஜீன் இல்லாம அன்னவரா இருந்துச்சு. So in 1960 to 1973 they started developing the closed blood bag system. Because of that the proper sterility is maintained. Okay, so next வந்து so Karl Walter is called as the pioneer in translation and storage of blood. So he only started the storage of blood and he was one of the person who started the world's first blood banks also. So next is the common anticoagulants used and எதுக்கு எதை யூஸ் பண்றாங்க. So whole blood வந்து as I said most commonly we are using ACD, that is acid citrate dextrose. This is most common used. Apart from that we are using CPD, that is citrate phosphate dextrose solution, and citrate CPDA1, citrate phosphate dextrose adenine solution. These three are reliable. Heparin and EDTA are not much reliable. So next வந்து RBC packed red cells ல என்ன மெயினா யூஸ் பண்றோம்னா CPD SAGM SAGM அப்படின்னு சொல்லுவோம். SAGM என்னன்னு பார்த்தீங்கன்னா saline, adenine, glucose and mannitol. These three இந்த ரெண்டு காம்பனன்ட்டும் மிக்ஸ் அப் ஆகி it gives a proper structure and integrity to the red blood cells. ஸோ அதே வந்து நெக்ஸ்ட் லெவல் தட் இஸ் ஃப்ரோசன்ல 5 years வரைக்கும் வி கேன் ஸ்டோர். ஸோ அதுக்கு என்ன பண்றோம்னு பார்த்தோம்னா கிளிசரால் வி யூசிங். கிளிசரால் என்ன ஹை கிளிசரால் சொல்யூஷன், லோ கிளிசரால் சொல்யூஷன் வச்சு ஃப்ரீஸ் பண்ணிடுறோம். ஸோ தட் இஸ் தி ஃப்ரோசன் ஸ்டேட் ஆஃப் தி ரெட் பிளட் செல்ஸ். ஸோ இப்போதான் ஆக்சுவலி பேசிக்கலி டிபிக்கல் பிளட் கண்டெய்னர் அரேஞ்ச்மெண்ட் எப்படி இருக்குன்னு பார்த்தோம்னா ஃபர்ஸ்ட் டோனர் வராங்க, அதுக்கப்புறம் அந்த எடுக்கிற மெத்தடிக் பேர் தட் இஸ் வினிசெக்ஷன். எது டேரக்டா வினிசெக்ஷன் எடுத்தோம்னா வி கெட் த ஹோல் பிளட். அதே வேண்டாம் பிளேட்லெட் மட்டும் வேணும்னு பார்த்தோம்னா இட்ஸ் கால் பிளேட்லெட் ஃபெரசிஸ். The platelet ferasis பண்றப்போ there are two types of platelet இருக்கு. One is a random donor platelet, next is single donor platelet. Single donor platelet எடுத்தோம்னா that is called as platelet apheresisல வந்து single donor platelet பண்றோம். சரிங்களா? சோ அடுத்து வந்து plasma pheresis அப்படியே plasma செப்பரேட் பண்ணோம்னா அதுல வந்து we have a product. That is என்ன ப்ராடக்ட் பார்த்தோம்னா plasma components and plasma derivatives வரும். The plasma componentsல FFP fresh frozen plasma and cryoprecipitate அது ரெண்டு தான் மோஸ்ட் காமனா எடுக்கிறோம். அந்த பிளாஸ்மா டெரிவேட்டிவ்ஸ்ல பாத்தீங்கன்னா ஆல்புமின், கோஆகுலேஷன் ஃபேக்டர்ஸ், இம்யூனோகுளோபின் அதெல்லாம் வந்து பண்றோம். ஸோ வந்து இப்போ வினிசெக்ஷன் டைரக்டா பண்றப்ப என்னன்னு பார்த்தோம்னா வி கெட் த ஹோல் பிளட் வரும். அந்த ஹோல் பிளட்ல இருந்து வி கேன் செப்பரேட் தி பிளேட்லெட், ரெட் பிளட் செல் as well as தி பிளாஸ்மா. ஸோ ரெட் பிளட் செல்ஸ் வந்து எடுத்த உடனே ரெட் பிளட் செல் டைரக்ட்லி வி ஹேவ் டு செப்பரேட் இன்டு a satellite bag. அந்த பேக்ல என்ன இருக்குன்னு பார்த்தோம்னா as I already mentioned the preservative material as well as anticoagulant ரெண்டுமே இருக்கும் to maintain the proper integrity of the blood. சரிங்களா? ஸோ வந்து ஆன்டிகோகுலண்ட் எது யூஸ் பண்ணா என்ன வயபிலிட்டி இருக்குங்கிறத we need to know. ஏன்னா நம்ம யாரும் படிக்க மாட்டோம், இதை மட்டும் பார்த்துக்கணும். என்னன்னு பார்த்தோம்னா ஃபர்ஸ்ட் ட்ரைசோடியம் சிட்ரேட் யூஸ் பண்ணிட்டு இருந்தாங்க. பட் என்ன ப்ராப்ளம்னா ஒன்லி 50% ஆஃப் செல்ஸ் தான் வயபிளா இருக்கு. ஹெப்பரின் அதே மாதிரி தான் ரேபிட் டிட்ரேஷன் இருக்கும். ஸோ இட்ஸ் நாட் வயபிள். ஸோ மோஸ்ட் காமன் வாட் வி ஆர் யூசிங் இஸ் சிபிடி, சிட்ரேட் பாஸ்பேட் டெக்ஸ்ட்ரோஸ். அதுல ஸ்டோரேஜ் வயபிலிட்டி பார்த்தோம்னா 28 days we can use. ஒன்ஸ் அந்த பிளட் எடுத்ததுல இருந்து 28 days we can use. அண்ட் சர்வைவல் 80% இருக்கும். டிபிஜி லெவல் இஸ் பெட்டர் மெயின்டைன். டிபிஜி லெவல் எதுக்கு இம்பார்ட்டன்ட்? That is only necessity for the oxygen transport. Hypoxic state la oxygen transport and oxygen absorption க்கு DPG is important. So we need to focus more on DPG level. அத வந்து CPD anticoagulant வந்து ப்ராப்பரா மெயின்டைன் பண்ணுது. So they are using it. இன்னும் ஃபர்தரா ஹையர் கொஞ்சம் காஸ்ட்லி பேக்ஸ்ல CPDA1 and 2 இருக்கு. அது என்னன்னு பார்த்தோம்னா 28 days யூஸ் பண்ற பேக் இன்னும் 7 days இம்ப்ரூவ் பண்ணி 35 days we can use அப்படின்னு சொல்லுவாங்க. So CPD and CPDA can maintain the blood bag for 1 month we can keep it. ஸோ நெக்ஸ்ட் அதே மாதிரி ஸ்டோரேஜ் என்னன்னு பண்றோம்னா ஃபர்ஸ்ட் வந்து WBC ஐ மீன் ஹோல் பிளட் எப்படி ஸ்டோர் பண்ணணும்னா பிளட் பேங்க் ரெஃப்ரிஜரேட்டர்ல ஸ்டோர் பண்ணுவோம். டெம்பரேச்சர் இஸ் 2 to 6 degrees centigrade and expiry is 35 days for CPDA bag and 42 days for CPD SAGM bag. அது FFP fresh frozen plasma and cryoprecipitate பார்த்தோம்னா டீப் ஃப்ரீசர்ல ஸ்டோர் பண்ணுவோம். Temperature is -30 degrees centigrade and below. It can be used for 1 year. The platelet concentrate வந்து is mostly for platelet agitator and the temperature பார்த்தோம்னா 22 degrees centigrade யூஸ் பண்ணுவோம். But we should use only for within 5 days we have to use it with short expiry. And then the next is cryoporoplasma. This is also used in the freezer, that is -30 degrees centigrade. It has 5 years expiry date. ஏன்னா cryo அப்படிங்கறனால 5 years validity is there. So this is the I mean frozen blood. So frozen blood வந்து எதுக்கு யூஸ் பண்ண மெயினா எதுக்கு கண்டுபிடிச்சாங்கன்னா ஃபர்ஸ்ட் இஸ் ஃபார் வார் ஜோன்ல தான் ஃபர்ஸ்ட் வந்து கண்டுபிடிச்சாங்க. அண்ட் தென் மெயினா இன்னொன்று எதுக்கு பார்த்தோம்னா ரொம்ப ரேர் குரூப் இருக்கு, சம்டைம்ஸ் வெரி ரேர் குரூப் அது கிடைக்காது, பிளட் ஸ்கேர்சிட்டி இருக்கு, இல்ல ரொம்ப வந்து எக்கனாமிக்கலி டவுனான கண்ட்ரில இருக்கு, அந்த மாதிரி இடத்துல வந்து WHO promotes this and they maintain this setup so that the frozen blood can be made and then we can thaw it and use it whenever it is necessary. Okay, so red blood can be stored for a longer period in the frozen state. The frozen red blood cells improve the cell survival and increase the shelf life to 5 years or more. It has been seen that freezing and subsequent thawing can also lead to dehydration. Adunala actually, even though it's for 5 years, within 2 years only we can use it. So men most commonly use பண்றாங்க agent பார்த்தோம்னா glycerol and dimethyl sulfoxide, but most commonly uses glycerol. So for freezing வந்து என்னன்னு பார்த்தோம்னா ஐடியா என்ன சொல்றாங்கன்னா for freezing also blood collect பண்ணி within 6 days of collection you have to freeze. அதே if you have any other if you have more rejuvenating solutions இருக்கு அப்படின்னா expiry date, that is even 35 days, after 35 days also you can freeze the blood and use that enrichment medium to maintain the integrity. But we cannot give the credential about the எந்த அளவுக்கு இருக்குன்னு we can't tell, but although they for war front and emergency purposes we can use this. So what are the advantages? Advantage என்னன்னு பார்த்தோம்னா long term storage for rare blood groups, the transfusion requirement for the patients with antibodies against high frequency antibodies இருந்துச்சுன்னா we can use that, and the autologous donations we can for rare blood we can use, and the fewer febrile and allergic transfusion reaction happens in this condition because since it is frozen, it is free from certain bacterial organisms also, and lower incidence of alloimmunization to HLA and transplant recipients, and the ability to store the rejuvenated outdated blood. Even though it's outdated, we can rejuvenate it by giving the enrichment medium. So அது ஒரு advantage இருக்கு. And as I mentioned 2-3 DPG is the high level in this condition. So for oxygen capacity is more using this, and restoring stock the தீந்து போச்சு அப்படின்னா we எப்ப வேணுமோ we can thaw it and bring it back, so we can restore our inventory. So these are the advantages. Disadvantage என்னன்னு பார்த்தோம்னா high cost setup and short post thawing shelf life. So once thawing பட்டோம்னா within 24 hours we have to use it, and increase the red cell processing. Once regular process பண்ண the red cell வந்து loss ஆகிட்டே இருக்கும், so we can't anticipate எவ்வளவு போகுங்கிறது we can't find out, so that's the disadvantage. So myths and facts, இது most common layman க்கு even though யார் வந்தாலும் they have a myth என்னன்னா வெஜிடேரியன் வந்து பிளட் கொடுக்க மாட்டாங்க because வெஜிடேரியன் அயன் இருக்காது அப்படின்னு சொல்றாங்க. So we need to give awareness about that. There's nothing role about that அப்படின்னு, and giving blood hurt அப்படின்னு சொல்றாங்க with very painful position they used to say, but actually it's not more painful, it's even less than white of the ant. Other reactions can be contracted, but proper protocol to give proper sterilized blood கொடுக்கறனால there's no chance of getting any contracting any infection or any blood transmitted diseases, so we can give it straight away. So giving blood is time consuming. எல்லா busy practiceல வந்து time ஆகும்னு சொல்றாங்க, but not like that. Within 45 to 1 hour you can go back and resume your work. So this is the myth and fact. So next, the blood banking. This is the most important. What I want to stress about this is, blood banking we need to promote the blood banking, because even though setup is not much complicated, awareness is more. If nearby நிறைய blood bank இருந்ததுன்னா the reach will be more and the reach will be more useful. So அதனால the blood bank is என்னன்னா it's a vein to vein process. The process involves these steps, that is blood collection, testing, component separation, pre-transfusion testing, and issue of blood components. These are the steps involved in blood banking. ஸோ என்னென்னு பார்த்தோம்னா, ஸோ எதுக்கு கொடுக்கணும்னா ரெட் பிளட் செல்ஸ் வந்து யூஸ்வலி அங்கே ஆல்ரெடி மென்ஷன் பண்ணது தான். 42 days we can use it, 10 years we can ரெஃப்ரிஜரேட்டர்ல பண்ணலாம். எதுக்கு கொடுக்கணும்? டு இன்க்ரீஸ் தி அமௌண்ட் ஆஃப் ரெட் செல்ஸ் ஆஃப்டர் ட்ராமா ஆர் இன்ஜுரிக்கு we can give in severe anemia also. FFP வந்து மோஸ்ட் காமன் எதுக்கு எங்க வாங்குறாங்கன்னு பார்த்தோம்னா ஷாக் இல்லைன்னா பர்ன்ஸ் அந்த மாதிரி கண்டிஷன் தேர் கெட்டிங் 1 year in freezer we can store. The platelet concentrate எதுக்கு வாங்குறான்னு பார்த்தோம்னா இந்த எஸ்பெஷலி டெங்கு சீசன் இட்ஸ் மோஸ்ட்லி சீசனல் ஆயிடுச்சு இப்போ. Actually இன்னொரு I need to mention about platelet is there's over ordering and over wastage of platelets happening all over the world. என்ன அப்படின்னா when the season occurs and the patient comes, இப்போ platelet low ஆகுதுன்னா they started ordering the platelet. என்ன ப்ராப்ளம் அப்படின்னா within 5 daysக்குள்ள we should use it, பட் ஆனால் ஆர்டர் பண்ணி இப்போ பேஷண்ட்டுக்கு வந்து ரிவைவ் ஆயிடுச்சுன்னா they are not using it. So we should always have a proper rationale, and only when there's a need we should order the platelet in order to avoid the wastage of the blood products. So அது ஒன்று. The next is Cryoprecipitate வந்து 1 year we can use. So இதில் என்ன இருக்கு பார்த்தீங்கன்னா fibrinogen deficiencies அந்த மாதிரி ஏதாவது இருந்துச்சுன்னா we can use it. So next is வந்து blood. So whole bloodல என்னென்ன டைப் ரெண்டு நேம் மென்ஷன் பண்றோம். One is fresh whole blood and whole blood ன்னு சொல்றோம். The fresh whole blood என்னன்னா within 6 hours கலெக்ட் பண்ணி within 6 hours இருந்ததுன்னா that is called as fresh whole blood. So இதுல என்ன இருக்குன்னு it contains all blood elements. It is raw actually and contains plasma, anticoagulant, preservative and everything will be there, but within 6 hours. The whole blood in எப்ப சொல்றோம்னா when it crosses 6 hours we call it as the whole blood. இதுல என்னன்னு பார்த்தா red cells started suspended liquid plasma and anticoagulant mix ஆகி it becomes the whole blood. It comes in a separate bag. So இது என்னன்னா mostly we should avoid the fresh blood. ஏன் அப்படின்னா the first 6 hoursல we should not have completed any process. So அதனால it's very raw. அதுல என்ன இருக்குன்னு நமக்கு தெரியாது. So most commonly prone to disease transmission. That is என்ன சொல்றது the intracellular pathogen survive in leukocytes in fresh blood that is removed only by leukofiltration. We don't have time for that actually. Within 6 hours if we transfuse we don't have time for that. And also the syphilis வந்து cannot stay more than 4 days in the bedல 4 days இருக்க முடியாது. So within the அதுவே டெத் ஆயிரும். அதே மாதிரி மலேரியா இருந்துச்சு அப்படின்னாலும் it cannot survive more than 3 days. So ideally it's better to avoid the fresh blood and give only the whole blood. Fresh blood that is within 6 hours transfuse பண்றதை விட வெயிட் பண்ணி கொடுக்குற blood தான் better அப்படின்னு they are telling. And the immunological complication also due to WBC ஃப்ரெஷ்ஷா உள்ள இருக்கறனால அதுல என்ன ஆன்டிஜெனிக் ரியாக்ஷன் இருக்குன்னு தெரியாது. So transfusion associated graft versus host disease வரலாம். And the transfusion associated immunomodulation, HLA allogenization அதெல்லாம் வரலாம். And the next is the logistics problem. If we within 6 hours we cannot do anything, there is no time for component preparation பண்றதுக்கு டைம் இருக்காது, infection screeningக்கும் proper time இருக்காது. So we are giving the blood blindly. So ideally it's better to get the whole blood rather than the flesh blood. The component is the best advantage. என்னன்னா we are giving the right patientக்கு right amountக்கு right timeல எது தேவையோ அதை மட்டும் கொடுக்குறோம். So blood component is the best thing. And another thing is out of the group transfusion also possible. இந்த group தான் கொடுக்கணும்னு இல்ல. FFPக்குலாம் பார்த்தோம்னா இது மட்டும் group மட்டும் மேட்ச் பண்ணா போதும். இது RH தேவையில்ல. So out of group transfusion is also possible in case of emergency. So optimum preservation, only optimum preservation is necessary for the components. And the specific components are transfused appropriate dose எவ்வளவு கேட்கறாங்களோ அந்த அளவுக்கு we can allocate and give. And the rationale is used because to avoid the scarcity வராம we can prevent it. And next is the basic idea about எது எவ்வளவு கண்டெயின் ஆகும் அப்படிங்கிறது. நம்ம எல்லாம் எடுத்துருவோம், பட் எவ்வளவு வருதுன்னு நமக்கு தெரியாது. ஜஸ்ட் நம்ம ஒரு ஐடியாக்காக சொல்லி இந்த பேக் செல்ஸ் எவ்வளவு இருக்குன்னு பார்த்தோம். இது பேக் செல் பேக் உள்ள எவ்வளவு இருக்குன்னு பார்த்தோம்னா வால்யூம் வில் பி 180 to 60 ml இருக்கும். ஸோ ஹெமடோக்ரிட் நார்மலாக எவ்வளவு இருக்குன்னா 55 to 75 grams/day இருக்கும். ஸ்டோரேஜ் டெம்பரேச்சர் வந்து as I mentioned 2 to 6 degrees centigrade ஃப்ரிட்ஜில் வைக்கணும். ஷெல்ஃப் லைஃப் இஸ் 35 to 40 days. தட் இஸ் வித் த அசிட்டேட் வித் ACD இந்த மாதிரி ஆட் பண்ணி இண்டக்ஷன் மீடியம் போட்டதுக்கு அப்புறம் we can store it for 35 to 40 days ஸ்டோர் பண்ணலாம். டோசேஜ் ஆர் என்ன எக்ஸ்பெக்ட் பண்ணலாம் அப்படின்னா ஒரு யூனிட் ஹீமோகுளோபின் ஷுட் பி ரைஸ். ஒரு யூனிட் பிளட் கொடுக்குறப்போ ஒரு கிராம் ஹீமோகுளோபின் ரைஸ் ஆயிருக்கணும் அப்படிங்கிறத கட் ஆஃப். அப்படி இல்லை அப்படின்னா 3% ஹெமடோக்ரைட் ரைஸ் ஆயிருக்கும். ஒரு யூனிட் ஆஃப் பிளட்ல. ஸோ வென் டு செக் to check it next day. So that is the ideal thing. Hemoglobin should be checked next day. That's the ideal thing. In some people, I have already seen some people within 4 hours also they are checking. That's not necessary. So next is FFP. As the name indicates, fresh frozen plasma. It is frozen. இது எவ்வளவு இருக்குன்னு பார்த்தோம்னா கம்மியாக that is 220 ml தான் இருக்கும். இது என்னன்னா என்ன மெயினா மென்ஷன் பண்ணாங்கன்னா the plasma that is frozen within 8 hours from collection. As I mentioned 6 hours இருந்ததுன்னா fresh bloodன்னு சொல்றோம். அது within 8 hours குள்ள நம்ம freeze பண்ணிட்டோம்னா it's called as fresh frozen plasma. இது என்ன அட்வான்டேஜ்னா it must be ABO compatible. Need not be RH compatible, but it should be ABO compatible group match ஆனாதான் we should give this. Storage temperature பார்த்தோம்னா -40 degrees centigrade. Shelf life is 1 year. It contains all coagulation factors. எவ்வளவு இருக்குன்னு பார்த்தோம்னா 1 microliter per ml இருக்கும். All coagulation factors இதுல இருக்கும். So we are giving it for any burns patient and another thing. So next is platelet concentrate. This is the fancy term as far as I see. So என்னன்னு பார்த்தோம்னா ஒரு யூனிட் ஆஃப் பேக்கெட் செல் பெர் 10 kg of body weight அப்படி ஐ மீன் 1 unit of platelet concentrate per 10 kg of body weighட்ங்கிறத கட் ஆஃப். ஸோ 70 to 100 ml இருக்கும் இதுல 70 to 100 ml இருக்கும். பட் இது வந்து need not be AB and RH AB RH மேட்சிங்ல தேவையில்ல, டைரக்ட்லி we can give. That way we call the random donor platelet. But only special conditions எங்கேயாச்சும் உங்களுக்கு ரியாக்ஷன் நடக்குது அப்படின்னா மட்டும் we need to cross match and check it. So it should need not be it should never be refrigerated before infusion. Once வந்துருச்சுன்னா infusion பண்றதுக்கு முன்னாடி we should not refrigerate it. We should keep it in the room temperature and then only we need to give. But while storing, we store it in 20 to 24 degrees centigrade. எப்படி ஸ்டோர் பண்ணுவோம்னா agitatingல ஸ்டோர் பண்ணணும், அப்படியே வச்சுக்க கூடாது. The platelet need to be kept in a platelet agitator and stored in a temperature of 20 to 24 degrees centigrade refrigerator. And the shelf life is 5 days. That is, we should be used within 5 days. அதனால சொல்றேன், once இப்போ நம்ம எக்ஸ்ட்ரா ஆர்டர் பண்ணி வேஸ்டா போச்சுன்னா 5 days அப்புறம் திரும்பி யூஸ் பண்ண முடியும், வெளியே தான் போடணும். So we should always anticipate it and then only we need to order, because it can be ready within 2 to 3 hours. But the usage of the product is important. Also the waste பண்ணாம பாத்துக்கணும். That's what I'm saying. So next என்னன்னு பார்த்தோம்னா ஒரு யூனிட் பிளேட்டட் கான்சென்ட்ரேட்ல எவ்வளவு இருக்குன்னு பார்த்தோம்னா 5,000 to 10,000 இன்டர்நேஷனல் யூனிட்ஸ் இருக்கும். அதே வந்து சிங்கிள் டோனர் பிளேட்லெட் போயிட்டோம்னா ஒரு யூனிட்டுக்கு 30,000 to 50,000 பிளேட்லெட்ஸ் இருக்கும். 30,000 to 50,000. So that is the advantage of single donor platelet. So next is the cryo. The cryo என்னன்னு பார்த்தோம்னா the fraction of plasma that does not dissolve on thawing plasma at 4 degrees centigrade. இதுல என்ன இருக்கு பார்த்தா rich in fibrinogen, factor 8, factor 13, von Willebrand factor, fibronectin எல்லாமே இருக்கும். வால்யூம் எவ்வளவு இருக்குன்னு பார்த்தோம்னா 15 ml தான் இருக்கும். So it is the least component. 15 ml தான் இருக்கும், but வந்து very much enriched தான் இருக்கும். So next is single donor platelet. இது நிறைய இடத்துல போய் வச்சிருக்காங்க, பட் இட்ஸ் ஹை காஸ்ட், பட் இட்ஸ் வர்த். அவ்வளவுதான். ஏன் பார்த்தோம்னா அதுல வந்து என்ன பார்த்தோம்னா ஒரு யூனிட்ல வந்து நம்ம வந்து 10 to 5,000 ஆவரேஜா வச்சிருக்கோம். ஸோ அப்போ வந்து ரேண்டம் டோனர் பிளேட்டெட்டுங்கிறப்போ ஒரு பிளாக்ல வந்து 5,000 இருக்கும், இதுல வந்து 50,000 இருக்கும், 6 times more. ஸோ அதனால இது மோர் அட்வான்டேஜ். அதுவும் இல்லாம வந்து பிளேட்லெட் ஃபார் சிங்கிள் டோனர், ஒரு பேஷண்ட் வராங்க, அவங்களோட ஏஃபரசன் மிஷின் மூலமா we are taking the platelet and sending the blood back as a everyday process. So it is more sterility sterile இருக்கும், and the patient friendly, safe, donor friendly also. So we not watching external so one unit is around random donor platelet. ஒரு random donor platelet 6 units of random donor platelet வாங்குறதுக்கு பதிலா we can get 1 unit of single donor platelet. So advantage என்னன்னு பார்த்தோம்னா as I mentioned, reduce donor exposure and என்னன்னா HLA allogeneic அதெல்லாம் கம்மியா இருக்கும். reduces the intracellular pathogen transmission இருக்காது. So quality product இருக்கும். So வந்து transfusion reactions are very less in single donor platelet. So guidelines, இது என்ன கைட்லைன்ஸ் பார்த்தோம்னா சில டைம் கிடைக்கல, எமர்ஜென்சிக்கு எப்பெல்லாம் பிளட் குரூப் பேரியர் மாற்றி கொடுக்கலாம் அப்படிங்கிறப்போ இப்போ வந்து ஓ பாசிட்டிவ் பேஷண்ட் இருக்காங்கன்னா அவங்களுக்கு வந்து பேக்ட் ஆர்பிசிஸ் வந்து டோனர் ஓ கொடுக்கலாம், டோனர் எஃப்எஃப்பி வந்து ஓபி ஏஏபி தான் கொடுக்க முடியும். அதே டோனர் பிளேட்டட் கான்சென்ட்ரேட் வந்து ஓபி ஏஏபி கொடுக்கலாம், இது குரூப்ஸுக்கு. ஸோ வந்து அதே வந்து பார்த்தோம்னா இப்போ வந்து இது வந்து குரூப்ஸுக்கு வந்து இது இம்பார்ட்டண்டா இருக்கு. வேற வந்து இப்போ ஆர்ஹெச் பேரியர் எப்போ ஆர்ஹெச் பண்ணலாம் அப்படிங்கிறது இம்பார்ட்டன்ட். ஏன்னா இப்போ வந்து எஃப்எஃப்பி வந்துச்சுன்னா நம்ம ஆர்ஹெச் பார்க்க வேண்டியதில்லை, டேரக்டா வி கேன் கிவ். ஆனா வந்து எஃப்எஃப்பில வந்து வி ஹேவ் டு செக் வெதர் இது இருக்கா, எஃப்எஃப்பில வந்து வி ஹேவ் டு செக் வெதர் குரூப் இஸ் மேட்சிங் ஆர் வி ஹேவ் டு சி. ஆர்ஹெச் வந்து மேட்சிங்கான்னு பார்க்க வேண்டியதில்லை. ஸோ அது சப்போஸ் எமர்ஜென்சி கொடுத்தாங்கன்னா வழி இல்லை அப்படிங்கிறப்ப என்ன பண்ணணும் அப்படின்னா packed RBC வந்து we can give only the negative, positive to negative எப்போ கொடுக்கலாம்னா only as a life saving measure and also with the proper consent from the treating physician and patient's relative கிட்ட consent வாங்கிட்டு we have to give. And also ஆன்டி இம்யூனைசேஷன் தர தேவை கிடையாது எஃப்எஃப்பிக்கு. அதே பிளேட்லெட் கான்சென்ட்ரேட்டுக்கு என்ன பண்ணணும்னா we need to give anti-D வந்து இம்யூனோப்ரோஃபிலாக்சிஸ் கொடுக்கணும், 300 மைக்ரோலிட்டர் கொடுக்கணும் ஃபார் 7 பிளேட்லெட் ஃபெர்சஸ். ஒன்ஸ் கொடுத்தோம்னா இட் இஸ் ப்ரொடெக்டட் ஃபார் 7 யூனிட்ஸுக்கு இதுல ப்ரொடெக்ஷன் கொடுக்கும் பிளேட்லெட் கான்சென்ட்ரேட் கொடுக்குறப்போ. ஸோ தட்ஸ் அவ்வளோதான். இது வந்து நெக்ஸ்ட் இஸ் லூக்கோரெடக்ஷன். இது வந்து ஆக்சுவலி கொஞ்சம் ஹெமட்டாலஜி என்ன பேருன்னா லூக்கோரெடக்ஷன் மெயின் எதுக்குன்னா ஃபீவர் இருக்கு, பேஷண்ட்டுக்கு வந்து ஃபீவர் இருக்கு, அந்த மாதிரி இருக்கிற டைம்ல we can give this to prevent the bacteria. ஸோ என்ன அட்வான்டேஜ்னு பார்த்தோம்னா இட் prevents the febrile transfusion reaction and the prevention of the HLA allogeneic அதுக்கெல்லாம் கொடுக்கணும். ஸோ இது மெயினாக டன் பை தி ஃபில்டர், மெனி ஃபில்டர்ஸ் அவைலபிள், பட் அவர்ஸ் ஸ்மால் செட்டப் நாங்கள் பண்றதில்ல, பட் மெனி கார்பரேட் ஹாஸ்பிட்டல் are doing that depending upon the need. So because depending upon the filter we will remove the leucofiltration is done. ஸோ தெரபியூட்டிக் ஏஃபர்ஸ் அதே தான், எந்த ப்ராடக்ட் வேணுமோ அந்த ப்ராடக்ட் மட்டும் எடுத்துட்டு பாக்கி இதை we will return it back to the blood stream. So next is antibody screening. Antibody screening is important அப்படின்னு பார்த்தோம்னா it involves the patient's or donor serum against the 2 or 3 antigen antibody reaction பார்க்கணும். There are 2 types of antibodies. One is expected and unexpected antibody இருக்கும். So expected antibody என்னன்னு பார்த்தோம்னா that is normally occurring body வந்து expected இருக்கும். அன்எக்ஸ்பெக்டட்ங்கிறது அதர் தென் ஏபிஓ தவிர வேற ஏதாவது கெல் டஃபி அந்த மாதிரி வேற ஏதாச்சும் இருக்கா அப்படிங்கிறத we need to see. அது இருந்துச்சு அப்படின்னா we need to take a proper care and then only we need to give the transfusion. So இது ICT DCT as we all know அது வந்து பார்த்து செக் பண்ணிட்டு தான் we will release it. Next is cross matching. Cross matching also we know. The cross matching they will ask a sample. Patient sample வந்து சென்ட் பண்ண சொல்லுவோம் டோனரை ஐ மீன் ரெசிபியன்ட் அவங்க வந்து அட்டெண்டர் கொண்டு வந்து கிராஸ் மேட்ச் பண்ணி we will give it. ஸோ இதுதான் கிராஸ் மேட்சிங். ஒன்ஸ் ரெசிபியன்ட் சீரம்ல வந்து 2 drops ரெசிபியன்ட் சீரம் 1 drop இந்த 1 drop டோனர் ஆர்பிசி போட்டு இன்குபேட் பண்ணி பார்க்கணும். இப்போ வந்து அக்ளூட்டேஷன் ஆயிடுச்சுன்னா இட்ஸ் நாட் கம்பேட்டபிள், அக்ளூட்டேஷன் ஆகலைன்னா கம்பேட்டபிள். ஸோ இந்த கம்பேட்டபிள் பிளட் தான் we need to give. ஸோ எக்ஸ்பெக்டட் மென்ஷன் பண்ண மாதிரி எக்ஸ்பெக்டட் என்னன்னு பார்த்தோம்னா எக்ஸ்பெக்டட் ஆன்டிபாடிஸ் வந்து ஆன்டிபியோட எக்ஸ்பெக்டட் தட் இஸ் நேச்சுரலி அக்கறை ஆன்டிபாடி அது இருந்துச்சுன்னா ஓகே. அன்எக்ஸ்பெக்டட் எதுன்னு பார்த்தோம்னா இந்த 2 types தட் இஸ் ஆலோ ஆன்டிபாடி அண்ட் ஆட்டோ ஆன்டிபாடி இருக்கு. அதை வந்து we need to address the issue and then only we have to check for the transfusion. So this is the extended topic. So next என்னன்னு பார்த்தோம்னா இது ஃபர்தரா கிளினிக்கல் ப்ராக்டிஸ்ல ஸோ இப்போ ஹீமோலைட் நியூபார்ன் இருக்கு அந்த மாதிரி இருக்கிறப்ப என்னன்னு பார்க்கணும்னா O நெகட்டிவ் கொடுக்கணும். பேக்டு ஆர்பிசிஸ் தட் இஸ் K நெகட்டிவ் தட் K குரூப் ஆன்டிபாடி நெகட்டிவ் corresponding antigen negative blood கொடுக்கணும். and AB fresh frozen plasma கொடுக்கலாம். mostly leukoreduced. the leukoreduced and irradiated இந்த எல்லா இதுக்குமே blood பொறுத்த வரைக்கும் leukoreduced and irradiated blood தான் கொடுக்கணும் depending upon the need. அதுக்கு வந்து தனி இப்போ transfusion department வந்தனால they are doing it very well. So that they will be more, they can explain more detailedly. So next is intrauterine transfusion. This is most commonly done now. இதுல என்னன்னு பார்த்தோம்னா இதுலயும் பார்த்தோம்னா irradiated தான் கொடுக்கணும் to prevent the transfusion associated graft or the host disease avoid பண்றதுக்கு we are giving. And most commonly என்னன்னா blood warmer has to be used. ஏன்னா வந்து temperature intrauterine temperature வேற மாதிரி இருக்கும், வெளியே வேற மாதிரி இருக்கும். So blood warmer has to be used and the blood should be given as fresh as possible. It's better to have an in-house blood bank. அதுக்கு தான் I'm stressing in many hospitals more than 100 bedded hospitals it's better to start a blood bank to care of the society. So இது வந்து thalassemia most common. இதுல என்னன்னு பார்த்தோம்னா check for the antibody screening for each transfusion and the leukoreduced blood product இருக்கான்னு பார்க்கணும். If unexpected corresponding antigen negative blood product என்ன இருக்குன்னு பார்த்து அதுதான் we need to give. And maternal blood sample is required. Maternal blood sample is checked and we should be given as fresh as possible. That is before we need to transfuse. So வந்து pre-transfusion என்ன informed consent. Now it has made a mandatory. நிறைய blood banks வந்திருக்கு. But many blood bankல பார்த்தா ப்ராப்பர் ரேஷனே இல்லை. They are just for name sake they doing. அது என்ன சிஸ்டம் ப்ராப்பரா இருக்கணும் அக்கார்டிங் டு கவர்மெண்ட் பார்த்தோம்னா இன்ஃபார்ம் கன்சென்ட் இருக்கணும் இன் போத் லெஜிபிள் லாங்குவேஜ் as well as தி காமன் லாங்குவேஜ். பிளட் ரிக்வெஸ்ட் ஃபார்ம் ப்ராப்பரா என்ட்ரா இருக்கான்னு பார்க்கணும். பிளட் சாம்பிள் வந்து பேஷண்ட் ஷுட் பிரிங். அது எதுக்குன்னு பார்த்தா கிராஸ் மேட்சிங் and collect 1 unit at a time. இதான் ஸ்ட்ரெஸ் பண்றாங்க. We should always collect 1 unit at a time except during mass transfusion. Unless there is a need, we should not collect more than 1 time. One unit has to be collected. After just before transfusion, the blood product should be handled with the fragile and handled with care. ஏன்னா ஸ்டாஃப் நர்ஸ் நிறைய பேர் அன்ட்ரெயின் ஸ்டாஃப் நர்ஸ்ல பார்த்தோம்னா வார்ட்லேயே சும்மா அப்படியே சுத்திக்கி போட்டுருவாங்க. எப்போ போட்டுட்டு போன ஷிஃப்ட் போட்டுட்டு இதோட ஷிஃப்ட் மாதிரி போயிடுவாங்க. நெக்ஸ்ட் ஆள் வர்றப்ப எப்போ வச்சாங்கன்னு தெரியாது. ஸோ பிளட் பேங்க்ல இருந்து கலெக்டட் பிளட் ப்ராடக்ட் எப்போ வந்து உங்க ஹாஸ்பிட்டலுக்கு வந்துச்சு, வார்டுக்கு எப்போ வந்து எவ்ரிதிங் ஷுட் பி ப்ராப்பர்லி மெயின்டைன். ஏன்னா அந்த 4 hourங்கிறது இம்பார்ட்டன்ட். வித்தின் 4 hours we need to transfuse. அது டிரான்ஸ்ஃபியூஸ் பண்ணலன்னா இட்ஸ் பெட்டர் டு ரிட்டர்ன் த பிளட் பேக் டு தி பிளட் பேங்க். இல்லைன்னா டோன்ட் ட்ரை டு ரீட்ரான்ஸ்ஃபியூஸ் இட். ஓகேங்களா? So next one பார்த்தோம்னா start the transfusion as soon as possible. Do not pre-medicate the patient. Do not give any medication. கொடுக்காதீங்க. Do not warm the blood units. Ideal to give the blood unit in the room temperature. Do not next important என்ன do not mix the blood bag vigorously. vigorously mix பண்ணக்கூடாது. இருக்கிற blood product அப்படியே வந்து ஹரிசாண்டலா லை டவுன் பண்ண வச்சுட்டு டெம்பரேச்சர் மேட்ச் ஆன உடனே we should start giving. So during transfusion, use the blood set with filters. If leukoreduction வேணும்னா filters வச்சு transfer, especially for the babies in pediatrics. Filters we are using, and do not use any syringe for blood transfusion, especially neonates and infants. Do not use any syringe for blood transfusion. Use only the ideal blood IV set, and then document the blood bag number, type of component, vital, start time, end time, அதெல்லாம் ப்ராப்பரா மென்ஷன் ஆயிருக்கணும். And start the transfusion slowly. monitor the vitals and look for the transfusion reaction irka அப்படிங்கிறது frequent check பண்ணனும். Better an attender and better the staff nurse should be near the patient during the transfusion. After transfusion, use the IV line only for blood transfusion NS. வேற எதுவும் blood எதுவும் மிக்ஸ் பண்ணக்கூடாது, மல்டிவிட்டமின் அந்த மாதிரி போடக்கூடாது. யூஸ் only the for blood transfusion NS மட்டும் தான் யூஸ் பண்ணணும். If any transfusion reaction is suspected, stop the transfusion straight away and inform the blood bank direct straight away. So இப்போ வந்து transfusion reaction வந்துச்சு சஸ்பெக்ட் பண்றோம், என்ன பண்ணணும்? Immediately stop the reaction. Keep the IV line open with the normal saline. வேற எதுவும் அந்த சைடுல வேற எதுவும் போடக்கூடாது. IV line ஓப்பனா வச்சுட்டு நார்மல் saline மட்டும் ரன் பண்ணிக்கணும். அப்புறம் blood component வந்து attached tubing, urine sample எல்லாமே we should remove it with proper paper workup. ஆல்ரெடி நம்ம இது ஃபார்ம் கொடுத்துருப்போம், transfusion reaction form எல்லாமே ப்ராப்பரா மென்ஷன் பண்ணி எத்தனை மணிக்கு என்ன ரியாக்ஷன் வந்து everything we should need to mention properly and then return it back to the blood bank for a proper workup because we need to work up and find out the reason. ஸோ இது வந்து என்னென்ன மோஸ்ட் காமன்லி இருக்கலாம்னு பார்த்தீங்கன்னா கிளரிக்கல் செக் ப்ராப்பராக என்ட்ரு ஆயிருக்கு, அப்புறம் அதே பேக் தான் கொடுத்தோமா, மிஸ் மேட்ச் ஏதாவது ஆயிருக்கா அப்படிங்கிறத பார்க்கணும். அப்புறம் வந்து விஷுவல் இன்ஸ்பெக்ஷன் ஆஃப் தி ப்ரீ அண்ட் போஸ்ட் டிரான்ஸ்ஃபியூஷன் சீரம்ல வந்து கலர் சேஞ்ச் ஆயிருக்கான்னு பார்க்கணும், அதாவது ஜாண்டிஸ் இருக்கா, ஹீமோலைஸ் இருக்கா அப்படிங்கிறத செக் பண்ணணும். அப்புறம் டைரக்ட் கூம்ஸ் டெஸ்ட் பார்க்கணும், அதாவது ஆன்டிபாடி ஏதாவது மிஸ் பண்ணிட்டோமா அப்படின்னு பார்க்கறதுக்காக டைரக்ட் கூம்ஸ் டெஸ்ட்லாம் போட்டு பார்க்கணும். அப்புறம் ஏபிஓ வந்து கன்ஃபர்மேஷன் ப்ரீ டெஸ்ட் சாம்பிள் as well as post test sample ரெண்டுலயுமே ஏபிஓ செகண்ட் டைம் we are confirming ஏதாவது இருக்கா ப்ராப்பர் கொடுத்துட்டோமா நீங்க பார்க்கணும். அப்புறம் ரிப்பீட் கிராஸ் மேட்ச் also we have to be done. And then finally antibody screening. Nowadays in many setup there are the many multiple panels are there to do the antibody screening. அதை வச்சு we need to verify it again. So next வந்து என்னன்னு பார்க்கணும்னா look for free hemoglobin. as I said hemolysis இருக்கான்னு பார்க்குற free hemoglobin பார்க்கணும். பேஷண்ட் ஹிமச்சூரியா வச்சிருக்கா, மற்றபடி வேற ஏதாவது கிளினிக்கல் ஃபைண்டிங்ஸ் அது இருக்கா அப்படிங்கிறது we need to mention in the form itself. And hemoglobin எவ்வளவு இருக்கு, டிராப் ஆயிருக்கா, ஹெமடோகிரிட் எவ்வளவு இருக்குன்னு பார்க்கணும். அண்ட் மெயின்லி we have to check for LDH. LDHனா acute reaction. So என்னன்னா RBC once break ஆன உடனே LDHல we can find the value. LDH will be increased. Next வந்து as we all know haptoglobin. Haptoglobin will be decreased in acute intravascular hemolysis. It will be decreased. So normal with extravascular delayed it நார்மலா இருக்கும். So வந்து டிகிரீஸ் இருக்கு அப்படின்னு ஹாப்டோகுளோபின் we can check in the biochemistry department, we can check it. அப்புறம் வந்து bilirubin 3 to 6 hours அப்புறம் we can check for bilirubin also to check for any hemolysis jaundice. So transfusion reaction just சும்மா 3 slides என்னன்னா ஃபர்ஸ்ட் வந்து ரெண்டு டைப், ஒன்னு அக்யூட் இருக்கு, இன்னொன்று டிலைட் இருக்கு. அக்யூட்ங்கிறது வித்தின் 1 day வருது, 24 hours வந்து அக்யூட், அதுக்கப்புறம் டிலைட். ஸோ ரெண்டு டைப் இருக்கு. அதை தவிர எப்படின்னு பார்த்தா கிளினிக்கலி பார்த்தோம்னா ஃபிப்ரைல் ஏஃபிப்ரைல் ரெண்டு டைப் இருக்கு. அப்புறம் வந்து ஹீமோலைட்டிக் நான் ஹீமோலைட்டிக் இருக்கு அண்ட் இம்யூன் அண்ட் நான் இம்யூன் இருக்கு. இதுல என்ன ஃபைண்டிங் இருக்குன்னு we need to address it and then only we have to act. So basically this is the flow chart for the transfusion reaction. First acute and delayed ரெண்டு இருக்கு. acute வந்து within 24 hours. One is வந்து immunologic and non immunologic. Allergic and delayed, that is one day later வரது என்னன்னு பார்த்தோம்னா அதுவே ரெண்டு டைப் இருக்கு, immunologic and non immunologic இருக்கு. immunologicல வந்து ஹீமோலைட்டிக்ல என்னன்னு பார்த்தோம்னா டிரான்ஸ்ஃபியூஷன் அசோசியேட்டட் கிராஃப்ட் GVHD அண்ட் போஸ்ட் டிரான்ஸ்ஃபியூஷன் பர்பியூரா, இது ரெண்டுமே வந்து immunologic. நான் immunologicல பார்த்தோம்னா டிரான்ஸ்ஃபியூஷன் இன்டியூஸ் ஹீமோசிட்ரோசிஸ் அண்ட் நெக்ஸ்ட் இஸ் disease transmission. Disease transmission is very rare now, but sometimes it can occur if we miss any ஏதாவது செக் பண்ண மாட்டோம்னா we can miss it. அதனால அதை செக் பண்ணிக்கணும். இதான் வந்து ஃபார்ம் 3 டைப்ஸ் ஆஃப் ஃபார்ம்ஸ் இருக்கும். ஒன் இஸ் இன்ஃபார்ம் கன்சென்ட். இது எப்படின்னா பேஷண்ட் வர்றப்பே இதை மென்ஷன் பண்ணி கொண்டு வரணும், எந்த ரீசனுக்காக வந்து அவங்க கேட்கறாங்க அப்படிங்கிறத ப்ராப்பரா ஃபிசிஷியன் மென்ஷன் பண்ணி they should give that send along with the attender. அப்புறம் வந்து பிளட் ரிக்வஸ்ட் ஃபார்ம் மென்ஷன் பண்ணிடணும். ரிக்வஸ்ட் ஃபார்ம் என்ன வேணும், என்ன யூனிட் வேணும், எப்போ வேணும் அப்படிங்கிறத ப்ராப்பரா they should mention. என்ன டைப் ஆஃப் சர்ஜரி, தெரபியூட்டிக்காவா, சர்ஜரிக்கா, எமர்ஜென்சிக்கா அப்படிங்கிறது they should mention. அதுல எல்லா டீடைல்ஸ் இருக்கும். டேட் ஆஃப் கலெக்ஷன் ஆஃப் பிளட் குரூப், பிளட் பேக் நம்பர் இஸ் மோஸ்ட் இம்பார்ட்டன்ட். அப்புறம் டேட் ஆஃப் எக்ஸ்பைரி இஸ் ஆல்சோ இம்பார்ட்டன்ட். அப்புறம் வந்து பேஷண்ட்டுக்கு என்னென்ன ஃபைண்டிங் வந்திருக்குங்கிறது they need to tick it then and there. அங்கேயே அவங்க டிக் பண்ணி அவங்க அனுப்பிட்டு பிளட் பேங்க் they need to send it to the blood bank. ஸோ அவரோட டேக் ஹோம் மெசேஜ் என்னன்னு பார்த்தோம்னா the blood is basically a dangerous drug. It has to be prescribed only when necessary and should be necessary in a proper quantity, and try to avoid blood transfusion as much as possible. The blood transfusion not without hazards, but we should it should weigh the risk against the benefit in the concept that we need to give, and use the right product should be given at the right time to the right patient, and always avoid the single unit transfusion. Single unit transfusion there won't be purpose. So if you want to give, better already plan it properly and order it accordingly and then give in a single shot. So ஸோ என்னன்னு பார்த்தோம்னா நெவர் இதான் மோஸ்ட்லி சொல்லணும்னு நினைச்சேன். ஏன்னா மோஸ்ட்லி வந்து நெவர் வார்ம் ஆர் ரெஃப்ரிஜரேட், நிறைய இடத்துல தே யூஸ் டு வார்ம் ஆர் ரெஃப்ரிஜரேட், அது பண்ணக்கூடாது. நம்ம எப்படி சென்ட் பண்றோமோ அதே இதில் மோஸ்ட்லி ரூம் டெம்பரேச்சர்ல வி நீட் டு கிவ் இந்த ஸ்டார்ட் த டிரான்ஸ்மிஷன். இந்த பிளட் பேங்க்ல இருந்து ஹாஸ்பிட்டல் ரீச் ஆன உடனே வித்தின் 30 minutes ட்ரை டு ஸ்டார்ட் தி டிரான்ஸ்மிஷன் அண்ட் கம்ப்ளீட் இட் வித்தின் 4 hours as I mentioned. Complete it within the 4 hours. 4 hours ஆகலையா, issue it back to the send it back to the blood bank. Never add any medication to the blood unit. Even in that line, அந்த லைன்ல வந்து எதுவும் ஆட் பண்ண வேண்டாம். Never pre-medicate the patients. So start the bill start பண்ணனும்னா for 10 to 20 drops per bit start பண்ணனும். Most slower we need to do it. And then FFP வந்து பார்த்தோம்னா FFP வந்து we can give it across RH groups. Groups கொடுக்கலாம், பட் வந்து எந்த groups வேணாலும் கொடுக்கலாம். ஓகேங்களா? அது ஒன்று. The platelet and cryoprecipitate can be transferred across ABO or RH except infants தவிர platelet and cryo வந்து ABO or RH எதுக்கு வேணாலும் we can give it. And always as I mentioned avoid single unit platelet and plasma transfer. Single unitல purpose இருக்காது, so always avoid single unit. So that's all. So this is the I use say. If you donate money and save the society, நம்ம ஹீரோன்னு சொல்லுவோம். But if you donate blood and save life, we'll always become a superhero. The choice is ours. Thank you. Hello.
Sir, thank you, Karthick Prabhu sir. It was an exhaustive lecture.
Thank you.
எவ்வளவோ பிளட் டொனேஷன் இது பத்தி கேட்டிருக்கிறோம், பட் இந்த மாதிரி எக்ஸாஸ்டிவா நான் கேட்டதில்லை. இந்த ஃபர்ஸ்ட் டைம்
Thank you, sir.
this much exhaustively you have given points. The questions கேட்க முடியாத அளவுக்கு இருக்கு. But anyhow, at the end of the second session, we will have the discussion, sir. So now I invite Dr. R.M. Subbaiah. I request Dr. Ravi sir to introduce Subbaiah Ramanathan because he only introduced him to give the lecture. So I invite Dr. Ravi to introduce him, sir.
Thank you, sir. Thank you so much. Actually, when Dr. Rajesh Babu asked about the stem cell donation, I thought Dr. Subbaiah will be the ideal person because in our Trichy district, he was the first person to do the stem cell transplant. Dr. Subbaiah is actually a student of Madurai Medical College. So after completing his MBBS, he did his post-graduation MD at PGH Chandigarh. And CMC Vellore is the known place where all of us have sent our cases for bone marrow transplant all these years. So he is a student of CMC Vellore, and he will now give us a talk on the bone marrow transplant. Usually bone marrow transplant, when we say it is mentioned, it is meant only about hematopoietic stem cell transplant. Recently, we have got this mesenchymal, but we mention bone marrow transplant, it is always about hematopoietic stem cell transplant. So now I request Dr. Subbaiah sir to start his lecture.
Thank you, sir. Good evening, one and all. Sir, am I audible, sir?
Yes, doctor.
Sure.
Yes,
Thank
sir,
you.
you're clear.
Sure. Okay, so briefly, we'll go through the basics of bone marrow transplantation and then the importance of stem cell donation. So where do we find the donors usually? And in case if we don't have matched donors within the family or relatives, what we do then? And shortly on the work, what we do in the Tier 2 city. Okay, so very famous, this is Dr. Donald Thomas, who received the Nobel Prize in 1990 in medicine for his amazing work in bone marrow transplant, and it's well published. And so what is a bone marrow transplant? This is a process in which an abnormal marrow or the diseased bone marrow, which could be due to a genetic pathology or an acquired cause, which is destroyed and it's replaced with hemopoietic stem cells. So that will produce the healthy blood cells. That's red cells, white cells, and platelets. All the three lineages will be produced by the new stem cells which has been infused after destroying the pre-existing bone marrow which is deceased. So that is the definition for a bone marrow transplant, and it's a curative procedure in many instances of blood disorders mainly, and it can help in patients with bone marrow failure, that is aplastic anemia or myelodysplasia or PNH, paroxysmal nocturnal hemoglobinuria, or the rare stem cell disorders, and all hematological malignancies like AML, ALL, CML, CLL, and primary immunodeficiency in pediatric patients, and even in some adults who have been diagnosed late, provided they are fit enough to undergo a bone marrow transplant. And especially HLH at the pediatric age group, the hemophagocytic lymphohistiocytosis, which could be sometimes a part of the inherited syndrome, also is cured by bone marrow transplant. And rarely autoimmune disorders also, when the immunosuppression doesn't work, very refractory to all these drugs and biological agents, sometimes people have tried this as the last modality of treatment. So those are the broad categories where one would benefit from a bone marrow transplant, like bone marrow failure, hematological malignancies, primary immunodeficiency, and related disorders like HLH, and last is autoimmune disorders. So if you compare the bone marrow transplant or hemopoietic stem cell transplant with that of a solid organ transplant like a liver, kidney, and other organs, in BMT, what we do is, apart from changing the hemopoietic system, the immune system is also changed. So that's the main important difference between these two. Whereas in a solid organ transplant, we transplant the organ and then immunosuppress the patient. Whereas here, the immune system is also new, which has to cope with the host and recognize the antigens. Okay, so the types of transplant, one is allogenic, the other is autologous. Allogenic is a donor donates his or her stem cells for the transplant. So that's a different individual who donates the stem cells to the deceased patient. And autologous is where the patient's own stem cells are collected and they are used for transplant. That is, once the disease is treated initially, and once the disease gets under control, we collect the stem cells and then we destroy the patient's marrow and then reinfuse. So it's basically a rescue therapy where the idea is to give the high dose chemotherapy so that we can salvage from the cytopenia period. So here one individual donates to the other, whereas here the same individual stem cells will be used to rescue from the cytopenic period. So that is allogenic and auto. So for example, if you go through this flow chart, it's easy to understand. So a diseased patient, for example, a patient with aplastic anemia or a leukemia, he undergoes bone marrow ablation with either chemotherapy with or without radiotherapy. Those are the two modalities by which one's bone marrow is destroyed. Then donor donates stem cells from the peripheral blood or bone marrow, and that is infused to the patient, and that goes and establishes itself in the bone marrow which has been destroyed already. So new cells from a donor will go to the ablated marrow of the patient, and then the patient will start producing red cells, white cells, platelets from the new stem cells of the donor. So that is what is called as allogenic bone marrow transplant. In autologous, once the patient, for example, a patient with myeloma, lymphoma, once we treat them, get the disease under control, then we collect stem cells. Sometimes it is used freshly as in myeloma. Sometimes as in lymphoma, we cryopreserve under minus temperature, and then they are reinfused back after ablating the marrow. So collect the stem cells, destroy the ones under patient is the disease under control, then destroy the marrow with chemo or plus or minus radiation, and infuse back the stem cells, which will again establish hemopoiesis and produce red cells, white cells, and platelets. So this is autologous transplant. So that's the difference. So either chemotherapy or radiotherapy, what we use to ablate the marrow is called as a conditioning regimen. And if the stem cells are frozen for cryopreservation, then it has to be thawed before infusion. Otherwise, fresh cells, as in myeloma or the usual allogenic transplant, we just time properly and collect the stem cells from the donor accordingly where he has to get infused, and then infuse them freshly into the host. Okay, so for example, this is a patient with leukemia. For pre-BMT, he'll have disease, he'll get treated. So those are the patient's cells, and then he'll undergo conditioning, or that is with chemotherapy or radiotherapy, to ablate the marrow. Then marrow becomes empty like this. So it's almost like an aplastic after treatment with conditioning regimen. Then the donor cells will go to this bone marrow and then populate, establish themselves, and produce all red cells, white cells, and platelets. And then we'll see the new cells in the peripheral blood that will be from the donor. So that is how transplant works. So the stem cells, what we collect from the bone marrow or the peripheral blood, which is more common, they have a capacity to differentiate into all these hemopoietic cells, all these blood cells, monocytes, granulocytes, platelets, red cells, lymphocytes, plasma cells, and osteoclasts. So any genetic disease or an acquired disease of the blood system, the hemopoietic stem cells hematology can be corrected with this bone marrow transplant. And one important thing is HLA typing. So 6 major antigens, this A, B, C, DR, DQ, and DP are usually seen to match between the patient and the donor whoever we are screening. And if they are matched, they are HLA identical, and that will decide whether the chances of rejection is there or not. The more if its HLA is identical, the chances of rejection is less in comparison to half matched or haploidentical individuals, where they might need some more additional modification of the conditioning regimen or GVHD prophylaxis. Again, the more the mismatch, there is a higher the chance of graft versus host disease. So those two things you have to remember. So before transplanting an allogenic, this is only for allogenic transplant, not for autologous. When we do an allogenic transplant, we HLA type the individuals with the donors who are supposed to be screened to find who is the match. And then if they're identical, then we use them as the donor, and that is to lower the chances of rejection and lower the chances of GVHD. So the HLA is there in chromosome 6. So that's from the pathology. And those commonly we see for A, B, C, DR, DQ, and DP. And that's the gene map of the HLA region in the chromosome 6. So that's the order of priority. We choose the donors. The HLA matched sibling, sister or brother, that's the best match if they are HLA identical. If sometimes the siblings may not be matched, but relatives might be matched HLA 12 by 12. So then we might take the relatives. It could be a father or mother also sometimes. If we don't get a matched sibling or a relative within the family, then we need to check for unrelated donors, which is also an important part of discussion today. And if we don't get even unrelated donor from any of the registry, or if we don't have time to search for these, sometimes we still go ahead with mismatch or haploidentical donors. And the other thing is the cord blood, which is not widely in practice. So those are the different registries: NMDP or National Marrow Donor Program, DKMS, Marrow Donor Registry, DATRI, which is the most prominent donor registry in our country, and Jeevan Stem Cell Bank. So those are the few examples where we might get an unrelated donor donated stem cells. And if you see the ASBMT guidelines, they also say that it's well, the question about cord blood banking, if it's a public banking, they encourage to donate the newborn's umbilical cord stem cells to be banked, whereas in private storage is generally not routinely recommended, as the chances of usage is very low down the lane. So indications for BMT, if you see, allogenic, as in leukemias like AML, ALL, CML, sometimes CLL, and inherited conditions like thalassemia, major primary immunodeficiencies, and other rare genetic diseases like mucopolysaccharidosis and other immunodeficiency states. And rarely in very refractory myelomas, we sometimes, or lymphomas, we consider allogenic, though the first line is still autologous for myeloma or lymphoma. So autologous is for myeloma, lymphoma mainly. Sometimes people have tried AML autologous transplants, especially when donors are not available and the patient is intermediate risk, but not in wide practice. And even some solid tumors like neuroblastoma also do undergo autologous stem cell transplant in some centers, and refractory autoimmune diseases also. So the reconstitution, if you see the pre-transplant one, that's the neutrophil numbers. So with transplant, once the conditioning regimen is given, the entire marrow of the patient or the host shuts down. So there is no more production of neutrophils or other myeloid cells. Those platelets all won't be formed. Then once the donor cells are infused here, that is day 0, slowly the donor cells will populate the marrow and they'll start producing red cells, white cells, platelets over a period of 10 to 14 days. By end of 2 weeks, the donor stem cells would produce all the red blood cells, which will be available in the peripheral blood. The initial early engraftment period is maybe up to 100 days, and then later it's a late or the post engraftment period. The engraftment is where unsupported, the neutrophil count from the donated stem cells, they cross 500 per microliter, and platelets more than 20,000 without support in the previous 2 days. So the donated stem cells will populate the marrow. They'll form red cells, white cells, platelets. Early engraftment period and late engraftment periods are things we should, terminology which we should know. And here the neutrophils and platelets come once it's 2 weeks. Then amongst the immune cells, other immune cells, NK cells come, then B cells, followed by T cells. So it might even take 1 or 2 years for the cell-mediated immunity to establish like the pre-transplant, provided there is no significant GVHD. So stem cell source could be from the bone marrow, which was used in earlier days, and now it has come down in practice, as most of all of us collect from the peripheral blood, and rarely some centers do practice cord blood. But in our country, the practice of cord blood transplant is challenging with the longer period of neutropenia and infections, and availability of cord may not be sufficient enough. So the most common stem cell source is peripheral blood, then is bone marrow, and the last is cord. So in bone marrow, bone marrow stem, so if you see the donor is taken to the theater under anesthesia, multiple aspirations from the ileal crest are done to collect maybe 200 to 250 ml, depending on whatever is needed. And in the peripheral blood, it's very, that's the most commonly done, just like a platelet apheresis, like any other donation. But the only thing is the donor has to be there in the blood bank for maybe 3 to 4 hours until a sufficient amount of stem cells have been collected. This is by GCSF mobilization. So granulocyte colony stimulating factor would be administered to the donor for 3 to 4 days, 4 to 5 days time prior to the transplant. So the colony stimulating factor will bring these stem cells out of the marrow. So those cells will start circulating within the peripheral blood. So we'll slowly see the total count going up. By day 5, it will become maybe 50, 60,000. So that's the right time to collect. And sometimes we even check the CD34, which is marker for stem cells, to know how much stem cells have come out or being mobilized from the marrow to the peripheral blood. So administer GCSF, bring the stem cells out from the bone marrow to the periphery, and just collect like a platelet apheresis over a time of 4 to 5 hours. So here there is no anesthesia, and if the veins are good enough from the cubital fossa itself, it can be collected. In case if the veins are not prominent, then sometimes the donor might need an insertion of a venous catheter in the jugular, subclavian, or femoral regions for the brief procedure which is being planned. And last is cord blood, which is just collected from the umbilical cord. The quantity would be small here, and sometimes an adult patient may not have an adequate amount of cord there. And once the conditioning is given and the stem cells are collected from the donor, then that is infused to the patient who is in the BMT ward. So as simple as that, it has to be just infused into the vein. Usually they have a central venous catheter or a Hickman's tunnel catheter. So it's just infused into that. And just like how blood is being given, it's administered. That goes, it finds its home in the because stem cells, they are there in the bone marrow. So based on those receptor interactions, it goes and homes there. And until the stem cells start functioning, which might take 2 weeks time, until the neutropenia and thrombocytopenia recovers, the patient is usually kept in the isolated room under high efficiency particulate air filter or the HEPA filtered room to prevent chances of or reduce the chances of fungal infection. And the food and water has to be safe. So most of the centers would pressure cook the cooked food already before giving it to the patient, and usually UV treated and the boiled water is being used. And that's the flow chart, which tells about the recovery of neutrophil. That's the neutrophil engraftment. So here, for example, once after destruction, after giving the conditioning regimen, the pre-existing patient stem neutrophils all would drop down, and it will take maybe for 10 to 14 days for the donated stem cells to form neutrophils. And generally we see neutrophils may emerge in the peripheral blood, appearing maybe by day 8 to 10. It would start by day 14, 15, it becomes normal. And when we administer GCSF, it sometimes comes faster. So during the cytopenic period, we don't see any white cells in the peripheral blood film. Once at the time of engraftment, that's the most joyful moment for any transplant physician, to see the neutrophils appearing in the blood. And those 2 weeks of cytopenia, intensive support would be needed in the form of irradiated packed cells. Whenever the hemoglobin is low, the cutoff may be 7 grams or 8 grams, depending on the institute protocol, and it has to be irradiated to prevent transfusion-associated GVHD before transfusing the individual. Similarly, platelets have to be irradiated, and intensive the febrile neutropenia during that period, with so much amount of mucositis, antifungal prophylaxis and antibiotics would be required until neutrophils appear. Once the neutrophil appears, all those mucositis created by chemotherapy, radiotherapy would heal, and the patient would start taking orally. They might need total parenteral nutrition also if the mucositis is so severe. Those are the different complications we expect in the transplant period. So one is regimen-related toxicity, that is due to the chemo or radiotherapy itself. When we administer agents like cyclophosphamide, it can cause hemorrhagic cystitis, inflamed bladder wall, which can cause hematuria or severe burning sensation. Veno-occlusive disease of the liver might happen due to conditioning agents like busulfan, sometimes cyclophosphamide. Liver function would be deranged, bilirubemia would be there, transaminitis would be there, and sometimes coagulopathy can also ensue. And some drugs may also cause interstitial pneumonitis. So bladder wall, lungs, and liver could be damaged by these chemotherapy or radiotherapy agents. And after engraftment, or at the time of engraftment, we might see this complication called graft versus host disease. If it happens within the first 100 days, it's acute GVHD. After 100 days, it is called chronic GVHD. So that is the donor T cells, whatever has been infused with the what is there in the graft, which will identify foreign and the host tissues as foreign, and it will start causing damage. So that is acute GVHD, and acute GVHD is more like an inflammation. It commonly involves skin, gut and liver, rarely lungs. Chronic GVHD is more like a fibrotic phenomena, like what we see in scleroderma or systemic sclerosis. So there, the fibrous tissue would start depositing, often skin, lungs, or musculoskeletal system would be involved. So acute GVH is up to 100 days and chronic is after 100 days. There might be overlap. Patients might also develop acute and chronic GVHD, and it's usually due to the donor T cells causing damage to the host organs. And we also see viral infections. So first 2 to 3 weeks, it could be herpes simplex virus. Generally, we give acyclovir prophylaxis here, and the chances of CMV reactivation or adenoviral cystitis or pneumonitis can happen within the first 100 days, especially when the immunosuppression is more for GVHD. Or after 100 days, we might see varicella zoster infections also. And on the fungal aspect, until the neutropenia, we often see candida, and after that, we might encounter aspergillus. But the chances of all these infections go up whenever the patient is on more immunosuppression. So whenever the patient develops GVHD, we are forced to increase immunosuppression, and with immunosuppression, we have to watch for all this. And these chances are more in patients with a haploidentical transplant, where we have to give more immunosuppression. Bacterial, the cultures will guide us always. So most often we see gram-negative bacilli and gram-positive sometimes. It's mainly due to the gut translocation, and sometimes we might see encapsulated organism in problems also. And those are pictures to tell you about GVHD. GVHD of the liver will be usually seen as hyperbilirubinemia. Usually it's a direct bilirubinemia, and sometimes transaminitis is seen. And if it's chronic, liver might go for fibrosis. The patient might also present with ascites. And if it involves gut, profuse watery diarrhea would be there. Depending on the quantity of diarrhea, volume of the stools, we would grade the GVHD, and the skin might present as erythematous macular, sometimes maculopapular rash involving body surface area. The grading depends on how much percentage of body surface is being involved. So those are 3 organs commonly involved. Usually the skin and GI followed by liver is what is involved in an acute GVHD. And to see the success of the transplant, a test what we do is called as chimerism. So that is, a chimerism is when an individual has DNA of 2 different DNAs. So the tissue, the host DNA would be there, and the hematopoietic stem cells would be from a different donor, and that would produce red cells, white cells, and platelets. So in the Greek mythology, lion's head, goat's body, and serpent's tail is what is mentioned as chimera. And there are some markers which we see on a post-transplant sample. Those markers which are different, we always map collect a pre-BMT sample from the patient as well as the selected donor to follow up the post-transplant chimerism. So depending on that, whatever markers are there, we would see whether the donor's markers are available in the blood. If that is there, then obviously it says that these blood cells are being formed from donor's stem cells. Obviously the cost of the transplant is more in the Western countries, and in India, it's way less in comparison to the Western world. And we know that from the father and mother, the chances of having a matched sibling donor amongst the siblings is only 1 in 4 chances. That is 25% only. There is a chance of 25%. That is the maximum that one individual can have HLA identical donor when other siblings are being tested within the family. So we need HLA identical donors for allogeneic transplants where we don't have these matched siblings or matched related donors or matched parents. The chance of parents being a match is very less. In that case, we need the help of the different registries in the world, and one such, the most widely known Indian registry is DATRI, which was founded in 2009, and that's the largest registry to register voluntary blood stem cell donors. And that's because that's the only hope for some disorders like high-risk leukemias, relapsed leukemias, or immunodeficiency disorders, or genetic conditions like thalassemia. And the sad thing is, such a huge populous country, and only a very small amount, or less than 2% of the population, is registered as stem cell donors. And there's a huge need. We need to increase the donor pool so that a lot of our patients could benefit in getting a donor. Because we know that ethnicity is an important factor. Indian patients if they get an Indian donor, that would be better rather than getting a foreign donor. So the registry has a vision we envision a society in which every patient in need of a life-saving blood stem cells is provided with an opportunity to find a HLA matched donor. And the mission is to create a registry of committed voluntary tissue or HLA type donors where they are well informed and willing to donate to the patient. So slowly we are seeing an increasing and the donors registry, donors registered there in the DATRI. And obviously the lives, those are the numbers of where the unrelated transplants have helped in salvaging or saving patients. So till June 2024, almost 1,400 patients have been benefited from getting matched stem cells from an unrelated donor, and almost 5.6 lakh individuals have been registered till June 2024. And a lot of donor recruitment drives have been conducted, and the 32 hospitals which have been registered, which have been partnered for stem cell collection when the donor is found at a distant site, which is the usual scenario. And that's the number which of patients who have been benefited, and to service 216 hospitals in India as well as abroad, where depending on where the HLA matched stem cells are required. And the headquarters is at Chennai, and those are the different cities where services are available. And thus, as I mentioned, ethnicity plays a significant role in finding an unrelated donor match. And India being so diverse, it needs to recruit donors within India as much as possible. And registry of donors of Indian background can help not only most of our patients, sometimes even patients from other countries also might need. So over 137 registries are there worldwide, and 41 million donors are there. And the collection of peripheral blood is almost, that's the number, that's more than bone marrow. And unrelated transplant was first performed in 1973. And in India, through DATRI, it was first in 2011. So the registration process is very simple. One is to know about this through an awareness session, either the registry initiated or through some social media somewhere. And we have to fill up the particulars in a form, and the eligibility is from 18 to 50 years of age, sign a consent, and just send a buccal swab, a properly collected buccal swab, and a donation of 1,800 rupees. That is to at least help the registry into HLA typing, which is more costlier than that when we do for our patients. And then the registry finds the HLA typing, and it's available in the registry, so that any patients who match might be the stem cells might be collected from the donor after a consent, if the donor is willing. So that's the registration form which is available, which should take few minutes to fill. Those are the swabs. So it's collected from the buccal mucosa, and it is sent, and HLA is typed from the registry. So in the peripheral blood, in the donation process, if you see, the peripheral blood stem cell collection is similar to what I have told earlier. Like just like a platelet apheresis, the donor is put onto that bed, and blood comes through one of the veins. It goes to the machine. After the stem cells are being separated, it returns to the other line. In case if peripheral veins are not accessible, the donor might require insertion of a venous catheter through the jugular, subclavian, or femoral. So verification of typing, then pre-screening to ensure that donor is safe to donate, and mobilization with GCSF, that is granulocyte colony stimulating factor, would be administered subcutaneously to the donor, so that all the stem cells from the marrow would come to the periphery. And 4 to 5 hour process of collection would happen in the blood bank, and collected stem cells are transported to the patient as early as possible, and it's infused to the patient in the hospital where the patient is being admitted and conditioned. Bone marrow harvest is similar, but there is no GCSF administered. After pre-screening, the donor is admitted to the hospital, and it's not so common to have bone marrow harvest, but it helps mainly in patients in benign conditions where we don't want much GVHD. Wherever the GVHD should not be more, as in benign conditions, in comparison to malignancies, the preferred way stem cell collection is bone marrow. But some in cities in developing countries like India, where we need to cut down the neutropenic period, generally bone marrow stem cells take a longer time than the peripheral blood stem cells to engraft. So that's why it's not commonly done in our country. So donor is admitted there, and then under general anesthesia, multiple aspirations from the iliac crest is done, and the stem cells are shipped to this place where the patient is there. DATRI also does a lot of work, which as I mentioned here: donor recruitment, HLA typing, and handle national search requests. So whenever we have a patient, we just send the HLA to them of the patient, and they would reply back to us saying whether the donor is available, what is the age group of the donor, as well as the blood group, and handle international requests also. And they also counsel the donor and family in case if a person needs stem cells somewhere, and they ensure all the master health checkup is done to ensure the safety before donation, and GCSF mobilization, like what we have told, and collection and shipping of the product to the hospital where the patient is there. And it also has membership with international bodies like WMDA by partnering. So the support is through organizing awareness session at different institutions, registration if possible, especially at educational institutions, and campaign to increase the chances of patient drives. Fundraising is also a part of that, so that the registry could be run, and interested individuals can always donate generously to ensure that the registry functions and that a lot of patients are being benefited. It has been under ATG tax exemption, and it has been in partner with large stem cell donors registry in India, and it has a lot of collaborations so that they would enable this life-saving procedure. So that is about whenever we don't have a matched sibling. So 1 in 4 chances we get a matched donor where the sibling or the parent or the relative might be HLA match. If that is not the scenario, then we need to depend on these unrelated donor registries to find a match. And in case if an individual who is a volunteer donor who has registered there in DATRI is willing to donate, then we might get the stem cells from the donor there. So we have started BMT in 2020. This being a tier 2 city, we had a lot of challenges. And because most of the BMT centers are there in tier 1 city, which has a population of more than 10 lakh, and establishing in a tier 2 city is always a challenge. And especially with a new transplant physician in a private sector hospital is again something which we have to look into. And here we share, briefly we'll share our experience, what we have done. We started for the BMT services for the first time here in Trichy, and those are the disorders what all we have transplanted: acute lymphoblastic leukemia, acute myeloid leukemia, mixed phenotype acute leukemia, where it has both properties of characters of myeloid and lymphoid, primary myelofibrosis, which is a myeloproliferative disorder, myelodysplastic syndrome, aplastic anemia, and Fanconi anemia. Those are bone marrow failure syndromes where marrow does not function and patients have cytopenia. Myeloma, lymphomas like Hodgkin's lymphoma, intravascular DLBCL, diffuse large B-cell lymphoma, peripheral T-cell lymphomas, angioimmunoblastic T-cell lymphoma, and plasmablastic lymphomas. Those are the lymphomas what we have transplanted so far, and some conditions like neuroblastoma, genetic conditions like thalassemia, osteopetrosis, Bair lymphocyte syndrome. So far we have done 73 in this tier 2 city. So 42 autologous and 31 allogenic. Haploidentical or half matched is 5, and unrelated donor is 2. Adults 58, pediatric 15 patients, and slowly our transplant numbers are going up. We started with 1 patient in 2020, then it was under 10 in 2021, 9, then 22, 19 patients, 23, 2023, 23 patients, and now hopefully would cross 23. So we are seeing a gradual increase in our practice, and those are the split. That's the all the disorders have been split there. Myeloma is the disorder where we have done the maximum number of transplants, followed by acute myeloid leukemia and ALL or Hodgkin's lymphoma there. So we presented our data in Indonesia. So we started with a 2-bedded unit, and now we have got 5-bedded HEPA filtered transplant unit in the Kaveri hospitals, and myeloma is the maximum transplanted condition. Like the usual standard discussion, the first-line regimen is the triplet agent with these drugs, and we try to achieve a very good or at least a partial response up to 65 years of age. With myeloma, we consider a transplant provided the patient has a good physical performance. Second-line agents, if these first-line agents don't work well, then we might consider more intensive regimens to get the patient under control. I've just mentioned myeloma because that's the disorder where we have done the maximum work. And like the usual recommendation, stem cell mobilization of bringing bone marrow stem cells to the periphery was done with a granulocyte colony stimulating factor, sometimes with a drug called plerixafor to enhance mobilization. And harvest was done by spectra optia apheresis system, which is a common system used by most of the centers. And most of our patients required a jugular venous catheter, especially the pediatric age group or age or individuals where the veins were not well visible. And in case of myeloma, we use melphalan as per the international recommendations, and a lot of supportive care would be needed in the form of antibiotics, mucositis care, irradiated blood products. We will give them all until engraftment and recovery of mucositis or defervescence. And that's the oral presentation we did at Asia Pacific BMT at Indonesia. And the challenge is in starting up a new center in a tier 2 city last year. And we had a lot of challenges, but still we could show that we can do this work in the Tier 2 city, and myeloma remained the most common disorder where especially a new hematologist starts his practice would start BMTs with. And it brings hope for both the patient as well as the new transplant team. And obviously, the cost of transplant in our country or our setup, we could do allogenic in less than $10,000 or autologous for $4,000 to $6,000 in Tier 2 city. And also the training institute should motivate and inspire residents to establishing services at places where they are not much available, rather joining an already established one into one of the tier 1 cities. And it's challenging and unmasks the talent of the new developing team, especially when we have a lot of challenges and major proportion of the population need not travel to Tier 1 cities or for high-end care. And patients can be close to their hometown. It cuts down cost, more emotional support is available when relatives are there, and expenses are likely to be less at peripheral cities than large cities. And post-transplant follow-up also becomes easy because the challenge is in just not the engraftment, then post-engraftment to ensure that the graft functions well without much GVHD or rejection there. And so we were pushed to start transplant during the COVID time when much patients could not be referred to other well-established centers. So we started, and then we could slowly go up on our numbers. So with that, we are trying to do our best with whatever resources are available. Then I would stop here. I'd be happy to answer questions.
Thank you, Subhaya sir. It was an exhaustive lecture, and all the points you have given in detail about there are a lot of questions as usual in our forum, and we will ask one by one. And
Sure, sir.
Dr. Karthick Prabhu sir, are you online? Karthick Prabhu sir?
Yes, sir.
There was a question stating that can secondary polycythemia person donate blood?
Yes, sir. We actually donated, sir. Actually, on the venous section they are giving. venous section போறாங்க. அதை வந்து actually we are using. இப்போ வந்து actually இப்போ அந்த mutation இருக்கு அந்த மாதிரி ஏதாச்சும் இருந்தால் மட்டும் தான் ரிஜெக்ட் பண்றோம். மற்றபடி அந்த venous sectionக்கு ரெகுலரா they used to give therapeutic venous sectionக்கு they used to send. அதை வந்து we are using only. அது actually it's better to give. Actually அவங்க actually கொடுக்கிறது better தான்.
That blood can be used.
Yeah. But unless it's proven, actually the primary lens proven ஆகி இருந்துச்சுன்னா we can use it. ஏன்னா இந்த கிளினிஷியன்ஸ் எல்லாம் சென்ட் பண்ணுவாங்க. they will suggest that ரெகுலரா இது இப்போ கொடுங்கன்னு சொல்லி அவங்க சஜஸ்ட் பண்ணுவாங்க. அப்போ வந்து அது வந்து செகண்டரி அப்படின்னு ஆச்சுன்னா we can give it.
Okay, sir. So one more question is, sir, can a patient donate if there are rheumatoid arthritis treatment? They are under treatment.
அது ஓகேங்க சார். அந்த ஆன்டிலெப்டிக் அந்த மாதிரி இது மட்டும் தான் we are deferred. இதுக்கெல்லாம் we can do.
Any possibility of the artificial blood in future?
Possible, sir.
Any absolute contraindication for blood donation?
Absolute is first.
Lot of things.
இல்ல absolute வந்து first வந்து இப்போ வந்து எதுனா drug absolute contraindication அந்த இதுக்கு சார் அந்த மெடிகேஷன்ஸ் நிறைய பேர் ஹைட் பண்ணிடுவாங்க. அந்த எபிலெப்டிக் ட்ரக் அந்த மாதிரி இதெல்லாம் ஹைட் பண்ணிடுவாங்க. அது வந்து நம்ம ப்ராப்பரா ஹிஸ்ட்ரி எடுக்கணும். அது வந்து அப்சல்யூட்னும். அதே மாதிரி அந்த டிராவல் ஹிஸ்ட்ரி தாய்லாந்து அந்த மாதிரிலாம் போயிட்டு வராங்க. அந்த மாதிரி ஹிஸ்ட்ரி சொல்ல மாட்டாங்க. அப்போ வந்து அந்த ட்ரக்ஸ் அந்த மாதிரி ஏதாச்சும் இருக்கு கையில ஏதாவது மார்க்ஸ் மாதிரி பார்த்தோம்னா அவாய்ட் பண்ணிடணும்.
Okay, sir. Impact of COVID on blood donation program.
அது இருந்துச்சுங்க சார். ஆக்சுவலி இப்போ ரீசெண்ட் என்ன சொல்றாங்கன்னா வித்தின் 2 வீக்ஸ்க்கு எதுவும் இல்லாம அது மாதிரி எதுவும் சிம்டம் இல்லை அப்படின்னா ஃபர்ஸ்ட் அந்த டைம்ல கான்ட்ரிபியூஷன் 6 months கொடுக்கூடாது 1 year கொடுக்காதுன்றது இப்பெல்லாம் அப்படி இல்லைங்க சார். இப்போ பார்ட் அண்ட் பார்சல் ஆஃப் ஆயிடுச்சு. எபிசோட் வருஷம் வந்துட்டு தான் இருக்கு. வேக்சின் சப்போஸ் போட்டிருக்காங்க ஏதாச்சும் போட்டிருக்காங்கன்னா 2 weeks மட்டும் டிஃபர் பண்ண சொல்றாங்க. அது பெட்டர் நம்ம 1 month வச்சுக்கணும். 1 month கழிச்சு கொடுக்கலாம்.
Then one question is plasmapheresis absolute indications and contraindications.
அது வந்து இவ கிளினிஷியன்ஸ் தான் சார். நம்ம ஆக்சுவலி இது பண்றது இல்ல. அது ஹெமட்டாலஜிஸ்ட் தான். Mainly plasma exchange helps in patients with Guillain-Barré syndrome or TTPs, thrombotic thrombocytopenic purpura, where we need to quickly get rid of the antibodies which are pathological. And contraindication, whenever the patient is hemodynamically unstable or florid or profound sepsis, it's difficult because we know plasma exchange, when it removes the pathological antibodies, it also removes the good antibodies, whatever are there. So it can increase the chances of infection. So during hemodynamic instability or sepsis, or sometimes an allergy, known allergy to FFPs, heparin, especially in the past, then we may not. Those are the common things which I could think of, sir.
Common legal issues in BMT and SCT.
In bone marrow transplant, obviously the lot of things, but usually it's a well protocolized procedure. So a lot of checks until we have all evidence, proper HLA typing from a quality lab which is very well quality controlled. We rarely we don't come across, because we counsel the patient about the possibility of rejection, relapse of rejection of the graft is well explained. Relapse of leukemias or malignancies is again well explained, and the possibility of GVHD. Patients might sometimes say that they didn't understand, but usually we counsel multiple times before taking up them for transplant. So that's most of the time, almost every time, we just ensure it's properly explained and it's well written, and it's there in the document in the patient's file before taking them for transplant. Without consent, we don't proceed, sir. So, and most of these conditions are being lethal. It's more almost everybody would take all precautions in taking them for transplant, sir.
Sir, actually you have described everything in detail about blood donation. Can we, one more question was there, can we donate, sir? How can we register it in solitaire கேட்டிருக்கிறாங்க. What my sincere request is that you give a small flyer like thing. Request
Sure.
at least the DATRI people to give a small flyer. In that, what are all the things, the sketch which you have put on the guidelines you have given? No, like
Yes.
that. If you start putting in, we will circulate among ourselves and to all the people regarding
Sure,
the
sir.
bone
Sure.
marrow transplant, sir. That is the my sincere request, sir. So
Sure,
that
sir.
it will be, this meeting will be
Useful.
useful eye opener for everyone, sir.
Sure, sir.
That is the main
I'll
thing
send it to you.
I wanted to request you, sir.
Yes, sir. Sure, I'll send it to you.
Because this HLA typing of the lip and this mucosa, buccal mucosa and all those things is a newer thing for us.
Yes.
Because we don't know this small thing.
I'll send you
that is the
the
main thing, sir.
yes, sir. I'll send you the things what to do for registration, sir.
And also you can give a small write-up, sir, about this bone marrow transplant and all those things, so
Sure,
that
sir.
we can publish in our bulletins, like in IMA bulletins. And even Karthick Prabhu sir also can give a write-up about
Okay.
the blood donation, sir, so that
Okay.
the points which you have covered here will be of much use to all the people, sir.
Okay.
So I could see one more question: any impact and outcome of BMT and stem cell transplant in male and female? So in general, for allogenic transplants, especially when we select the HLA matched donors, say for example, if 2 or 3 siblings are being matched, then always we prefer to select the male with the same blood group, preferably as the donor, in comparison to the female. When the male is not available, then obviously we select the females. Females we try to avoid, especially because during pregnancy they get allogeneic from the fetal DNA. So that is the main reason. The chances of GVHD is less when the male is a donor in comparison to females who have undergone pregnancy.
Sir, for steroid-resistant GVHD, have you used mesenchymal stem cells? Any center is using it, like
Yes, sir.
CMC? Vellore?
Yes, sir. CMC, when we were residents, we have seen very resistant GVHD. Steroid refractory GVHD carries a very high mortality, and a lot of immunosuppressive agents, all second-line agents also, sometimes like basiliximab or etanercept, cyclophosphamide, ruxolitinib, they might fail. And during my residency, there was one patient where mesenchymal stem cells were used, but it didn't really help us there, sir. But that is one
Sir,
scenario.
yeah.
Uh,
So
but
actually
not very
now,
commonly used. That maybe that is one thing we should that would be a bias because with the facilities, accessibility and availability, which is not like the other drugs, it's really difficult to comment on that one rare scenario, sir. But the public, there are
actually in
where it
India,
helps.
yeah, in India, actually, recently the government has approved mesenchymal stem cell therapy for 6 different diseases. So, mesenchymal stem cells are available ready-made. Allogenic bone marrow-derived mesenchymal stem cells are available for various diseases or indications. So, at some point of time, like when we use all the COVID drugs we used were off-label. They were not meant to be used for COVID, but we use them as off-label. So like that off-label use of mesenchymal stem cells, which are readily available. So they are available as 25 million in a bottle, 150 million, 200 million. So with the specific count and there. So at some, another thing is whether autologous mesenchymal stem cells. So if you can take the mesenchymal stem cells from the same patient before, and then you like how you do autologous hematopoietic stem cells. So that is, so these I think we can discuss for the future. It's not
Yeah.
available today, but I think for the near future, this should be one more possibility.
Sir.
There are no other questions. I think we can wind up the session. I think we have answered most of the questions. And from DATRI, this Mrs. Tilakavati has joined, and she was also giving a lot of information when I met her in Trichy. And so you send a small flyer like that, sir, so that we will publish and we
Sure.
will circulate among all the members. That will be of much use about the bone marrow, because this bone marrow transplantation and bone marrow donation and all those things are not that much familiar among the people. So if we give a small write-up and a thing, which will be very useful to our doctors, because lot of things the skin donation, like skin donation also not popular to among people. So during life we can donate blood. And as Karthik Prabhu was telling, every month, every year, at least once we have to donate blood. I don't know how many of our doctors themselves are doing blood donation. That is the main thing. We are not at all doing it. Even in our IMA, there is a award for the branch which is donating more doctors are donating the blood. Even that is also not happening. See, we should be standing as an example and doing things, but we are not at all doing it. That is the problem. We are also like our other people. That is the main thing. Okay, sir. So, at this juncture, I like to thank Dr. Karthik Prabhu, our blood bank medical officer of Indian Medical Association, Coimbatore, for giving an exhaustive lecture about blood donation, and Dr. Subbaya Ramanathan explaining everything about the bone marrow transplant and stem cell therapy. I thank both of you for giving a nice lecture and making this occasion a grand one. Thank you one and all the participants who are very much interested and join this program, and till the last minute they are all attentive. Thank you one and all. Thank you so much, sir.
Thank you, sir.
Thank you.